computer. There we go. So we've got 15 people in the waiting room. Jason is joining us a little bit later for his talk.
Shall I share my screen?
I'm not sure I'm going to be able to stop this because I can't get back on. There we go.
Have you shared your slides as backup with Anne and Debbie, just in case?
Yeah. I'm just trying
Okay.
to see if I can.
Debbie, do you want to share your slide again because it's 1 minute to 10?
Yeah.
So I'm going to let people in a second as well.
So how quickly do you want me to start?
I'll just need 2 minutes in the beginning, and then you have like 10, 12 minutes or so to give your talk about the ARC.
Okay.
And then it's Ben and Anna and Jason. So Ben, I'm going to make you co-host already now as well. Okay, so I'm just going to let people in. Right, so hello everyone. We're just letting people from the waiting room in now. People are trickling in. As you can see as well, this meeting is being recorded. So if you don't want to be recorded with your video on, just please switch your video off and mute yourself during all those presentations. So welcome to the Northwest Coast Household Health Survey virtual conference today. The Household Health Survey was conducted in 2015 and 2018, but we've wrapped up a lot of the analysis now, and we thought it'd be a nice way to celebrate and to showcase all of those findings in the virtual world. So just a few things before, we have quite a lot of talks going on today. So if you want to pop your questions throughout those talks in the chat box, we will pick them up after each talk, and we will discuss them with the presenters. And yes, really over to the first presenter, I think, to start us off on this conference. So first of all, we will hear from the director of the NIHR ARC Northwest Coast, Professor Mark Gabby, about the ARC. And Mark, over to you. You're on mute. Mark, you're still on mute. Sorry, everyone.
There we go.
There we go.
I've done it now. So I hope whether you can see the screen, but probably not the way I was hoping to show you, and that's because I'm trying to be too technological here. So can you now see the slides? Sorry, you're going to have the side show as well. I can't get rid of that. So just apologies. So good morning, everybody, and welcome to the conference. I'm Mark Gabby. I'm director of the ARC Northwest Coast. And I'm just going to run you through a bit of a background of who we are and what we are. So the ARC was established in October 2019. It's 135 million pounds of national funding from what's called the NIHR, and we're hosted by NHS Liverpool CCG. And as we were in the Clark, which was what preceded us for nearly 6 years, health inequalities is the main area of interest across all of the work that we do. So the Clark, which is where the HHS was undertaken, was a £22 million, nearly 6-year organisation and infrastructure, as we call it, of 38 partners focusing on health inequalities. We had over 100 projects, over 80, around 80 what we call knowledge mobilization internships for staff that worked in our member organizations. We had 3 waves of what we call a partner priority program, looking at reducing unplanned care and doing robust evaluations of those with some implementation work. We funded 25 PhDs and 5 master's students, and we developed about 150 publications, plus a lot of what we call bites and implementation guides, and the bites are on NICE. And over that time, we developed 10 neighborhoods for learning across areas of deprivation, low income wards across the northwest coast. And within both that and the Clark more widely, we had 170 odd public advisors working with us. So when we moved from the ARC, we held meetings with our members from the Clark and our public advisors and others, as you can see on these pictures, and we reviewed what we'd done in the Clark and what we wanted to do in the ARC. And those are our cartoon minutes that you can see there. So this is what we wanted the ARC to look like, as graphically illustrated. And we work together. And when we say we, this is what we means. It's a collaboration. It's all of the work that we do starts from the beginning with public advisors. When we say the public, they could be patients, they could be carers, they could have not been patients for quite some time. There may be community activists. There may be service users of various types, whether it's social care or healthcare for themselves or members of their family. So it's to get that wider experience from the population of the Northwest Coast about what they think health is and well-being is and what their experiences are. And then we also work with our organizations, and in the ARC we have over 60 members, and those organizations have a lot of staff of various types, and we work with them. And those organizations include 5 universities. So the academics from there are part of what we call when we say we. So we're a collaboration. And that's a map of the Northwest coast. Those are some of the dots of members. Actually, we have more than that because we have that map was done when we only had about half the number of organizations signed up as we have now. And we have £9 million in the ARC, and the ARC is running until 2024. And there's some big things that we've developed, which I've got on those links at the bottom there. The Health Inequalities Assessment Toolkit, we looked for a way for researchers to identify what equity meant for their research project from when they were first developing it with the public. And there wasn't one, so we had to make one. We built one ourselves in the Clark, and that's it, called www.hiat.org.uk, and that's currently just being refined in alliance with the School of Public Health Research in the Northwest Coast area as well, what's called Lilac, and we'll be sharing that new version in the coming months. Ben, who you'll be hearing from shortly, built with the survey that we're talking about today, plus other big data sets, something called Place-Based Longitudinal Data Resource, which is being picked up nationally and beyond, and beginning to influence the things that the government are doing because they're going into that data set to look at coastal health, for example. And I've talked about the neighborhoods. We had something called the Neighborhood Resilience Network. And this household health survey grew out of an interest around public mental health and social health and healthcare usage that was a combination really of what we had in the previous Clark, which was a mental health network theme and a public health theme that Rhiannon and Ben ran respectively. Why do we think about health inequality so much in the Northwest? Well, those red boxes, that's the Northwest and the Northeast in the middle there. So our life expectancy at birth for men and women, under 75 mortality rates for various things, suicide rates, they're all higher than the rest of the country. They're all in the red. And you can have up to 27 years of difference in healthy life expectancy across different parts of the Northwest. That slide moved without me even touching it. Somebody's trying to hurry me up here. So that's why health inequalities are so important to us. That's why everybody agreed that's what we should focus on. And that's what we're trying to do. And in the ARC, we're continuing to focus on that, but we've got much more implementation happening in the ARC. thinking about how we can get research into practice. But it's all about local delivery of research with impact is what we're trying to do. And we're trying to bring the best research from around the ARCs and elsewhere to bear on trying to reduce health inequalities and improve health and well-being. And the ARCs also work nationally. They work on combined projects on different themes. So this is how we're structured. We have 4 research themes: improving population health, person-centered complex care, equitable place-based health and care, because place-based care is a big thing in the new NHS, and then health and care across the life course, which is the one I lead. Ben leads the improving population health one. And then we have 2 cross-cutting themes, the methodological support one and the care and health informatics one. Impact is about implementation, and this is what I was talking about before, about finding out what the best evidence is that's relevant and bringing it together and working on how we can get it to make a difference in the real world. And this is a diagram to try and show how we're constructed. We're looking at mental health and physical health as part of the same thing. It's about engaging with our members and building capacity in our members for research through co-production and knowledge exchange. And there's that pathway from research through to impact across the different themes that I've shown there. And we do that research into practice through implementation to bring the impact at the end. You see, it's quite a complex organization. I'm not going to go through this, but this is how our governance structures work. And we have a management team and a steering board, and we ultimately answer to the NIHR and of course our members who are on the steering board and feed into that, and our public advisors through the Public Advisor Forum feed into that as well. And we have what we call delivery pipelines. All of this is on the web pages that we have, our website, so please look at that. And we've tried to illustrate how you develop a project from whether it's in for research, and the next one's about implementation, from the germ of an idea through to the results and the publications at the end, or making a change at, so to speak, the coalface or the population level later on. And one of the things that we're going to be talking about today is how you can look at that, looking at population data. So that was the research one, and this is the implementation one. And then finally, just to show you that our public advisors are fully embedded in everything that we do. We've thought a lot about how we put the public at the center of all the work that we do. Our public advisors are front and center from the beginning of our project through to being co-authors in the papers that we write at the end. And we have structures that we've set up to engage them. And we've also now appointed 2 public advisors for each of our themes as co-producers. This is an old slide. I can see one of our public advisors looking at this going, where's that from? And it's from when we were first setting the ARC up. And we've changed some of these graphics now into different ways of illustrating, but this conveys the same sort of idea. This was how we came out of the Clark and developed it for the ARC. But we're just revising our strategy, so some of these things will change in the way that we illustrate them. And our theme management groups are there to engage with our members, and our members, as I've described them already, which are bringing together the academics, the staff and the public. And they all work in slightly different ways, but as I say, we have our themes meet at different time periods depending on which theme it is, and they invite colleagues to join them and look at the projects that are being proposed and the progress with the projects that they're undertaking. And we have co-leads. The main lead is an academic, because that's what NIHR demands that we do to invest in us from an academic perspective. But we've also appointed public co-leads, and we're going through the process of appointing professional co-leads from our member organizations to represent them as well. And this is what we've managed to achieve in the 18 months so far. We've appointed 23 PhD studentships. 15 interns have been recruited. About £30 million of grants have been awarded either directly to us or projects that are linked to us and that we're supporting. We've got over 100 projects registered across our themes. We have over 70 public advisors working with us, and we have around 80 publications published so far in our 18 months. So if you see, compared to what we did in the Clark, we've almost done as much in 18 months of the ARC as we managed in 5 years plus of the Clark. And that's all I was going to say. I hope that's given you a rough flavour of what we're doing and how we're doing it. And please do look at our website. I've only given you a rapid run through there just to set this in context.
Great, thank you very much, Mark. So that's been a bit of an overview of our infrastructure of the ARC Northwest Coast. Does anyone have any questions? Just pop them in the chat box. But if there shouldn't be any questions, we are going to move on to Professor Ben Barr, who will give a talk about an overview of the Household Health Survey. So Ben, over to you.
Sorry, just remembering to remove myself off mute. Thank you, Clarissa. Can you see my screen?
Yes.
Yes, and a nice background of an island in the sea.
I don't know where that's come from.
That's fine.
Hopefully you can see the right screen here. So thank you, Clarissa, and welcome everyone. Yeah, my name's Ben Barr. I'm a professor in applied public health research at the University of Liverpool. And as Mark has said, well, in the Clark, these acronyms are quite horrible, but that was the collaboration for applied health research and care, I think, which was the previous iteration before we moved into the ARC, which is the applied research collaboration. So in the Clark, I was deputy lead for the public health team, and for the ARC, I'm a lead for the improving population health theme. So today, we're just going to give you a bit of an outline of the Northwest Coast Household Health Survey, because it's in some ways quite an unusual survey and has some particularly sort of unique aspects to it that have made it particularly useful for looking at some of the health inequalities issues that Mark has outlined. So when we set out to do this, so back in 2014, I guess it was, when we started thinking about it, we set out sort of objectives to try and design a survey that would help us understand some of the variations and reasons why some more disadvantaged communities have worse health than others, and what are the determinants of that, and to understand what that means in terms of how people are using healthcare services between those places, and for that to inform how we can build better services and support with those communities to address those health inequalities, work out what's working and what isn't, and to use that as a way of building capacity within the communities and within the public health system as a whole. So, as Mark said, this was particularly built around this group of neighbourhoods that we worked with throughout the 5 years of the Clark and into the ARC. These were 10 what we called neighbourhoods for learning, so they're relatively disadvantaged neighbourhoods in each of the local authority areas that were involved in the Clark, and the local authorities were involved in identifying those neighbourhoods that we then went on to work with. So they're shown by these sort of red dots on this map. So the survey was based in those neighbourhoods, and also a group of comparator neighbourhoods, so neighbours that were seen as relatively similar by those local authorities, similarly having sort of higher levels of deprivation. And in the first wave, anyway, we also selected a set of similarly sized neighbourhoods that were a bit more affluent. So that was the kind of initial kind of basis for the survey, to understand health and the things that influence health within those neighbourhoods for learning in a way that we could inform how to better develop services in those places. And to inform that work with those neighbourhoods, working with the local authorities and the residents in those places, we developed this system resilience framework, really, which was really focused on what kind of things needed to be developed within those neighbourhoods and within the institutions that influence those neighbourhoods that could help improve health and well-being. And that focuses around things that we know have a big influence on people's health. So things like the living environment, things like housing, public spaces, air quality, economic systems, so people's income, debt, their access to good employment, social relationships, so the relationships within the communities, but also the relationships between those communities and institutions like the NHS or local government, but also the identity that people have with the places that they live. And all of those interact with what we call community governance, which is really about how those communities can influence decisions that affect their lives and affect these other factors like the environment, the economy, and social relationships. What we felt was that to make any change sustainable, and those communities need to be involved in those decisions and need to be involved in influencing those decisions. So the crucial focus of our work was looking at ways we could help those communities better influence the decisions that affect them. And this was part of a program in the public health theme that was called the Neighbourhood Resilience Program. So the survey was constructed around that conceptual model. So there are questions related to each of those domains: the economic, environment, social relationships, and community governance. And then those potentially influence people's health status, but also how they use health services through various pathways. In particular, they can influence people's health through what are called sort of psychological pathways. So that might be things like people's sense of self-esteem, or people's feelings of hopelessness, for example, but as well as through kind of behaviors that we know impact on health. So things like people's physical activity, or smoking, or alcohol. And those have an impact on mental and physical health. So there are questions related to each of those pathways and measures of people's mental and physical health, and then also questions related to how people are using health and care services. So that sort of combination of questions allowed for some particularly useful analysis that we're going to hear about later today as to what are the potential pathways that are generating these inequalities. Obviously, we had an engaged process to develop the survey. As Marcus said, the ARC and the Clark before it are a collaboration across lots of different organizations and with members of the public. So we had a fairly intensive process with starting with that conceptual model and a program of engagement with each of the local authorities involved, because that's where the sort of place of the survey was taking place, but also the other members of the ARC, to piloting the survey and conducting the field work. So that was all led by a survey implementation group, which had representation from those members. And that led into the first wave, and then there was a kind of a refresh of that for the second wave. So the first wave took place in 2015-16, and the second wave in those same neighborhoods in 2018. So this just gives a bit of detail of those two waves of the survey. So in the first wave, we had the survey in these 10 neighborhoods for learning and 10 similar areas that we weren't working with specifically in those same local authorities that were sort of similarly disadvantaged, as well as these 8 neighborhoods that were a bit more affluent. In total, that was 4,319 people were interviewed, and the households were, the survey was conducted by a company called BMG, and they basically randomly selected households from each of those neighborhoods and then interviewed one person from each household who was also randomly selected. Then in 2018, we went back to the same neighborhoods. Where we could, we tried to re-interview the same household that had been interviewed in 2015. But where that wasn't possible, because people had moved house, for example, we selected an additional random sample of households. In the second wave, we only conducted the survey in those 10 neighborhoods for learning and those 10 comparison areas, a total of 3,212 people in the second wave. As Mark has said, that data from the first wave directly we made available through a kind of interactive resource for residents in those neighborhoods for learning, so that they could look at data from their own neighborhoods and how it compared to other neighborhoods in the sample. That resource is available through our place-based longitudinal data resource. So initially, the data was used with those communities to look at what were the characteristics of the factors influencing health within those neighborhoods. And then with the second wave, looking at how that had changed over time and what was the potential impact of work that we've been doing with those neighborhoods. So again, within the using the survey data, we derived 3 measures across those domains of our resilience model. So that involved combining data from lots of different questions in each of those domains to come up with a sort of indicator for each one. Looking at community governance, for that we actually only used one question, which was asking people about how they felt they could influence decisions affecting their local area. But around the environment, questions related to people's housing, condensation, mold, whether they were able to keep heat to their houses sufficiently. Lots of questions related to people's social contact and isolation, feelings of trust with others in the neighborhood, and questions related to people's economic livelihood, related to employment, financial security. So for each of those domains with the residents in those neighborhoods, we produced some infographics looking at how their neighborhood compared to the other neighborhoods for learning. So this is just an example from one of the neighborhoods, looking at, so the red circle there is kind of the average for all of the neighborhoods for learning, and then the purple lines show where this neighborhood was compared to those. And further towards the outside of the circle is better in terms of financial security, for example, the environment, governance, and social relationships. So this neighborhood, was sort of kind of average compared to the others and compared to the environment and governance, but worse off in terms of social relationships and economic systems. So that was then used to inform the kind of activities that went on with those neighborhoods. additionally, looking at the kind of health outcome data, we did sort of similar work with residents in those neighbourhoods to look at. This is just showing the kinds of different health problems and problems related to sort of disabilities that were reported within a particular neighbourhood. For example, this neighbourhood had more people with mental health problems than the average. And then with each of those neighbourhoods throughout the Clark, there was a programme of work focusing on different elements of that resilience model. So, for example, in Knowsley, in Stockport village, which was the neighbourhood for learning, there was a focus on community cohesion and environmental quality. And within each of the areas, there was a programme of work trying to involve residents and the local authority and other institutions in addressing some of those issues. So this is just an example of some of the work that was done in Stockbridge in Knowsley, where an artist was involved talking to residents to involve them in telling the stories of their place and what they felt was positive about it and how things could be improved. And as Mark has pointed out, there's a website related to the neighbourhood resilience programme in those neighbourhoods, which is at the bottom of that slide. So just looking at how things changed in those neighbourhoods, one of the sort of main things we were looking at changing was how people could influence decisions affecting their local area. And this just shows the proportion of people saying that they felt they could influence decisions compared to the yellow is the neighbourhoods for learning areas. So it's just under 40% saying they could influence decisions, and that increased over the time of the Clark in the second survey, whilst in the comparison areas they started off in a better position in that more people felt they could influence decisions, and that decreased. So potentially some evidence from that that there was an improvement in those neighbourhoods, in people's reporting that they could influence decisions affecting their local area. Whether that was down to the work that we've been doing in those neighbourhoods is hard to tell, but definitely some signs of improvement. So this shows how things changed across those dimensions. Basically, if the bars pointing to the left is where things got worse between the first wave and the second wave, and the bars pointing to the right is where they got better. So the blue bar here is this measure of people saying they can influence decisions. So that got better in the neighbourhoods for learning, but got worse in the comparison areas. For the sort of economic factors, which is the orange bar, that got better in both areas, slightly more in the neighbourhoods for learning, and the environmental factors got better in both groups of areas, but more so in the comparison areas. What is sort of noticeable is that the people's reported kind of social relationships, so the questions related to things like trust and social cohesion and social isolation got worse, quite a lot worse, in both the neighbourhoods for learning and the comparison areas over the course of the arc. And so that kind of relates to the kinds of things that we're going to be looking at in the rest of the talks today. So just in conclusion, this is quite a unique survey in that it's focused on these neighbourhoods and is focused on tracking changes in neighbourhoods over time. It was co-developed in partnership with local government and other members of the ARC and with the public, and it's constructed around this conceptual model of system resilience and the mediators for that, and has a wide application, both in looking at the improvements related to activities within the clerk, but also many other applications that we're going to hear more about today. So that's all from me. Any questions?
Great, thank you so much, Ben. That was great. So any questions, please just pop them in the chat box. There was one question from Nefin. I'm not sure whether it's been answered now, but Nefin was wondering about how physical activity was measured, Ben.
Sorry, what was that? Physical activity?
Yes, how was it measured?
It was a series of a standardized instrument. I'm trying to remember now, which was it's called the GPAC, I think. But it's a standardized set of questions that is quite often used in general practice for assessing physical activity.
Yeah, great.
There's a few in the chat, I think, aren't there?
Yeah, there was some about involvement in some of those areas and neighborhoods. So another question from Nefin was, I'm not quite sure in what relation, but was that change due to regression to the mean? That's his question.
It's difficult to, I mean, it's difficult to tell whether it was because of those places being worse. I mean, we didn't select them based on that measure, so the selection was really left down to each local authority. So, for it to be regression to the mean, you would have had to have really selected them based on that as being outliers on that measure, and you might expect it to kind of tend towards the mean. But it may have been something, but one of the characteristics that influenced the local government's selection. So there could be a problem with that.
Yeah, okay. That seems to be all the questions for now, but if you do have any more questions, just keep them in the chat box or maybe email Ben as well. So I'm just mindful of time, and our next speaker, thank you very much, Ben. That was really interesting, but I know the survey. But we've got Professor Anna Alfirovic, who will now be talking about, is polypharmacy associated with socioeconomic factors? So over to you, Anna.
Thank you very much. Can you see my screen?
Yeah.
That's great. So it's a fantastic opportunity for me to talk about pharmacology in this meeting. So I'm a professor of pharmacology and personalized medicine at the University of Liverpool. And it was a unique opportunity to look at polypharmacy within the household health survey. So we have looked at, polypharmacy is just one of the components of our study, but I will report today about polypharmacy and social factors. So we know that life expectancy is increasing, and in the UK, the fastest growing age group is those who are older than 65 years. And we know that many of people who are older have one or even more long-term health conditions, and they are prescribed multiple medications. Definitions of polypharmacy for this study were: polypharmacy was when individual was taking 5 to 9 medications at the same time for long-term health condition. And extreme polypharmacy was defined as taking more than 10 drugs at the same time for long-term health condition. We know that in the Northwest England, lower life expectancy for people in good health is present. So it's particularly important to look into multiple conditions and polypharmacy in the Northwest. Not all polypharmacy is problematic. So sometimes it's appropriate to prescribe more than one medication at the same time, and particularly in patients with cardiovascular diseases, they often have to take more than, they have to take several medications. But the differences between appropriate and problematic polypharmacy is that appropriate polypharmacy is evidence-based prescription and optimization of medication with the intent to improve quality of life. For problematic polypharmacy, it's based on non-evidence. It sometimes risks outweigh benefits. And what is very difficult for patients is that sometimes pill burden is unacceptable, and it could lead to what is called as prescription cascade, when medicines cause side effects, and then to treat those side effects, new drugs are being prescribed and so on. So it's called a prescription cascade. What are the consequences? So we know that drug-drug interactions are more common in when people are taking more than one drug, and also it can lead to increased number of adverse drug reactions, and obviously health costs with hospitalization potentially for very severe reactions. But what is also very important is that patients who experience adverse drug reactions would probably just stop taking medications. So adherence to medications is a problem, because they would be then at risk of developing diseases. So the aim of the study was to understand socioeconomic and demographic mechanisms of polypharmacy, and how do these relate to physical and mental health conditions. We used both waves of household health survey, and thank you, Ben, for describing the household health survey. So you can see the number of individuals that we looked at in the first and the second wave, and then repeated samples were for 871 people. And then in our analysis, we were either analyzing this separately or taking repeat measures away from our analysis. So there were a broad range of questions related to socioeconomic determinants of and physical and mental health, and the focus on inequalities in the survey, but there were also several questions on medications. Our outcome measures were the number of medicines taken in the past week. Then we looked at age, gender, ethnicity, level of deprivation, education and housing, and then some of the health measures for physical health and mental health. We also used lower layer super output areas to look at the distance to GP practices, walk-in units, and accident and emergency centers. So I won't be talking a lot about the analysis itself and the two different models that we use to analyze the data, but I will show some of the results from the negative binomial regression model, where we were looking at the increase of medications taken linked to factors that lead to that increase of medications. So we looked at a percentage of people in the whole cohort who were on no medications, and then 1 to 4 medications, and then polypharmacy. So nearly 18% of population was on polypharmacy. So it was both polypharmacy and extreme polypharmacy. We looked at medication types and sorted them out according to diseases. One of the limitations of this study was that all the medications were self-reported. However, some of the individuals, some of the participants would produce a list of medications, so it was checked, if possible, reporting of their medications. So you can see that the most commonly taken medications were analgesics, and then antihypertensive drugs, antidepressants, and then lipid-lowering medications, so statins. This is just one of the tables to show our analysis, and some of the p-values on the left. You can see that there are very, very low p-values, and what I would like to just summarize is on the previous slide, is that polypharmacy was associated in our study with several factors. Multimorbidity and advanced age were the most important factors, and we knew that from previous studies and from previous reports. But what was also interesting is that social deprivation, depression, and lack of education were associated with polypharmacy. For ethnicity, white population was had higher level of polypharmacy than different other populations, black and so on. Something to say about adherence. You can see that what is obvious here is that individuals with extreme polypharmacy find it more difficult to remember to take all the prescribed medications. What is also interesting to see is that mental health conditions were associated with a higher report of medication management difficulties, as well as individuals who have multiple conditions. They showed more difficulties with medication management. So I would like to conclude and say that polypharmacy was significantly associated with multimorbidity, advanced age, social deprivation, and depression. And the association between extreme polypharmacy and higher levels of income deprivation and neighborhood deprivation supports the view that reducing polypharmacy could be achieved by supporting interventions to reduce the gap in health inequalities. And what is also important to mention is that efforts to introduce deprescribing could benefit aging populations and those who have multiple physical and mental health conditions. So thank you very much. Publication on our study and on our data is currently in preparation and nearly ready to be submitted.
Thank you very much, Anna. That was really interesting. You've got a few questions in the chat box already. So Leo Singer is asking, was multimorbidity defined as physical, psychiatric, or measure of both combined, please?
We analyzed separately, physical and mental separately, but for this analysis, I reported combined results.
Okay. And a question from Sandra Smith. You state people often can't remember to take medication. Could pharmacists not be encouraged to supply blister packs?
Yes, absolutely, that's true. But one of the examples that I may give is not just difficulties remembering to take drugs, but also lack of adherence for instance, a good example is patients who are taking statins. When they have even mild adverse drug reactions, such as muscle pain or cramps in the lower extremities or any other adverse reactions associated with statin intake, they stop taking medication. So that's one of the really difficulties with adherence, and certainly in this study we couldn't measure adherence, so we don't know whether that was any problem. And as I said, it's self-reported, so maybe people who report difficulties there were specific questions on what are the difficulties, whether it was difficult to open the bottle with medication or any other, or forgetting to take, or there were some refined questions about that, but yes.
Yeah, I mean, yeah. We know from older adults with dementia that blister packs don't necessarily work, that they might be a little reminder, but they need someone else to remind them on top of that. There's a few more questions, one which may have been answered already. Nefin was asking what interventions are being used in the Northwest Coast to address polypharmacy. Are pharmacy technicians widely employed in practices? Question to you, Anna.
I don't know exactly of interventions that are, but what I do know is that there is a lot of clinical pharmacology research, particularly at the University of Liverpool, looking into deprescribing. So there is the whole new area of clinical pharmacology in looking at different interventions on how to tackle polypharmacy.
Yeah, and a comment I think in relation to that from Mark as well was all PCNs have pharmacists working on reviews, as do many practices, and blister packs are commonly used. There's loads of questions coming in there, Anna, so you've given a really interesting talk, it looks like. So one question from Justine Shenton was about, do you think prescription costs or likelihood of free prescriptions has an impact?
Prescription costs, sorry, can you perhaps elaborate on that? What is?
Justine, do you want to maybe explain that a bit more? Clarissa, I've made a comment in the chat about that. We did some work with people who'd had a stroke, and there is it's a big problem in the US about the affordability of prescriptions and people choosing what they can and cannot afford to take. In the UK, that would be people of working age, so between the ages of 18 and 60, who don't qualify for free prescriptions on the rules. And it's about 10 to 15% of the population that have to pay for their prescriptions. It's actually much lower than people think of those that take regular prescriptions. So that is an issue. And yes, as Nevin's just said, in Wales and in Scotland, there are no prescription costs. I don't think that study's been done yet. Sorry for jumping in there, Anna, but
Okay, so there is a question about do you think lower level of polypharmacy in BAME community reflects lack of care? We couldn't draw conclusions from our survey. That's quite an interesting thing, and whether they're taking less medications or reporting, going less to GPs or I don't know. We couldn't from our survey. This couldn't be answered really.
Mm-hmm. And I think we all we had obviously a smaller proportion of people from minority ethnic groups in the survey. Maybe underpowered to answer that question as well. There's one more question from Selina. Linking in with social prescribing. So is polypharmacy usually because people are taking unnecessary medication? Could this be addressed by social prescribing, reducing this?
I think that one of the problem is that very often, I'm not saying, I mean, there are GPs here among the audience, but it's very difficult to de-prescribe medications and to overrule the decision of a specialist. So I think that you know, if a cardiologist prescribes certain medications and then the individual has neurological disorders and then a specialist again prescribe. So I think that the problem is that, and what's happening now, certainly in Liverpool in our de-prescribing clinic, is that there is a multidisciplinary team who is looking at prescribed medications and then deciding on how to optimize treatment. And I think that this is a relatively new concept, that multidisciplinary teams are focusing just on medications and list of medications. And so I think that that's the way to tackle the problem.
Okay. Yeah, great. Thank you so much, Anna. Certainly lots of questions, so thanks to the audience as well. That's great. And now we've got one more presentation and then we've got a 5-minute break. So our next speaker is Dr. Jason McIntyre, and he will be talking about neighborhood belonging and mental health, pathways to resilience. So over to you, Jason.
Thank you very much. Can you see my PowerPoint?
Yeah.
Okay, also, I don't seem to have access to the new fancy slide template, or my research was supported by the National Institute for Health research, but I'll have to get those slide templates off someone. And I think it's also worth acknowledging today in our conference about inequalities that we're all attending today from a position of relative advantage, having access to the internet and access to technology that not everyone has. And I think it highlights the fact that this pandemic is potentially going to make health inequalities worse. So I think this research was important beforehand, but is going to be even more important going forward with the ARC. So my talk today is focusing on neighborhood belonging and mental health, and looking at whether belonging can be considered a resilience factor in some of the pathways from disadvantage to mental health difficulties. In addition to the sort of broad framework that Ben talked about earlier, the mental health theme, improving mental health theme of the Clark and now the ARC developed this, again, a broad theoretical model that we use to help guide our research and research questions of how we get from deprivation or disadvantage in communities to specific mental health symptoms. And you can see here, if we look at some of these deprivation factors, one possible pathway is that they lead to social problems and social issues such as lack of community belonging, such as incivilities, lacking support, and lacking trust within the community. These are then also linked to psychological precursors or psychological risk factors for specific mental health symptoms, rumination about negative events or circumstances, feelings of hopelessness, lower self-esteem, anticipating future threats, and not feeling in control of your own life. And these, we know from previous research, are linked to various specific symptoms depending on which psychological precursor is most prominent. And these include depression, anxiety, paranoia, well-being, which were all measured in wave 1, and self-harm, which is also looked at in wave 2 of the household health survey. So this was the broad model we were looking at when thinking about our predictions and research questions. I'm just going to go briefly over some of these sort of main effect findings, as this is going to be a theme that probably weaves through a lot of the talks that you'll hear today. So if we look at people's subjective reports of whether they were financially worse off compared to 12 the disadvantaged neighbourhoods for learning and the disadvantaged comparative neighbourhoods both report a higher proportion of people being worse off compared to the less disadvantaged neighbourhoods that were examined in wave 1 of the survey. And if we look at some of the mental health related measures, you see a similar pattern here. So the disadvantaged neighbourhoods, both the neighbourhoods for learning and the comparative neighbourhoods, had significantly higher levels of depression relative to the less deprived neighbourhoods, and also significantly higher levels of paranoia compared to the less deprived neighbourhoods. And the other measure relevant to my talk today is a measure of neighbourhood belonging that was included. And so you can see here the disadvantaged neighbourhoods for learning had the lowest levels of belonging, but both of these disadvantaged groups of neighbourhoods had lower levels of belonging, feeling like they belonged to their local area compared to the less deprived neighbourhoods in the sample. And finally, just to highlight this point, if we look at all the individual neighbourhoods in the survey and we ordered them from highest levels of depression to lowest levels of depression, you can see the disadvantaged neighbourhoods in blue here all have high levels of depression compared to the less disadvantaged neighbourhoods. And again, we see a similar pattern regardless of what mental health symptom we look at. We see similar patterns with anxiety and paranoia. And so what this suggests, disadvantaged neighbourhoods are experiencing increasing levels of poverty. They have worse physical and mental health symptoms, and they feel less like they belong to their local area. And so in some of the specific research questions that we developed, we're interested in testing whether feeling a sense of belonging to your community might reduce the risk of mental health problems that are associated with economic inequality or financial hardship. And so this first paper that included Ben and Richard Bentel and Sophie Wickham looked at identity. So identity here is social identity, which we use our measure of belonging as an indicator of social identity. So belonging is part of social identity, but social identity is feeling like you belong, but also incorporating that group that you belong to into your sense of self. So the theory that we use to come up with these models is based on social identity, but we can think of belonging as sort of a rough measure of how you identify with your local community. And so we're interested in testing this pathway from identifying with your local community to self-esteem to symptoms of paranoia, to see if this was a pathway that would develop in participants. Does feeling less like you belong, feeling like you don't belong to your community, lead to lower levels of self-esteem? And does this in turn lead to higher levels of paranoid symptoms? And so that is what we found. When we looked at symptoms of paranoia, the statistics are there for the statistician in the audience. They are unstandardized effects reported here, the B values, but you're looking at effect sizes of between 0.15 and 0.2 when we run this kind of research. So sort of small to moderate effect sizes, but I think it's important we're only only looking at one specific sense of identity or one specific type of belonging, which is neighborhood belonging. So I think when you take that into account, they're fairly important effects that we're seeing. And if I move to the next slide, we ran the same model with depression and we found a similar pattern. People who didn't feel like they belonged to their local area had lower self-esteem, and this in turn led to higher levels of depressive symptoms. What was also interesting in this particular study, the survey included a second measure of a symptom of psychosis. So the two most common symptoms of psychosis are delusions, feeling like other groups or other people are out to deliberately harm you in some way, and with very little evidence to support that belief. The other major symptom is auditory verbal hallucinations or hearing voices. And so this is a common symptom of people with psychosis, and often those voices that people hear are particularly negative and hurtful voices as well. And so we looked at this model in relation to this symptom as well, and we didn't actually see the same pattern of findings as we saw for paranoia and depression. We of course see the relationship between identity and self-esteem. People who felt like they belong had higher self-esteem in the sample, but there was no link between self-esteem and auditory verbal hallucinations, either indirectly through self-esteem or directly from community identity to auditory verbal hallucinations. And so this is quite useful to identify the specificity. If you implement interventions designed to increase belonging in the community, it's likely, or these findings suggest it's likely that will have an effect on symptoms of depression and paranoia, and also from other research we've done on it would help with anxiety as well, unlikely to help with hearing voices or auditory verbal hallucinations. Next study I'd like to talk about, which was led by my PhD student and Richard Bentel's PhD student, Anam Elahi, looked at the data from the Household Health Survey and looked at the subjective measures of financial stress, again looked at self-esteem and looked at symptoms of paranoia, depression, and anxiety in this particular study. And again, looked at this mediated relationship. Does financial stress lead to lower levels of self-esteem? And does this in turn lead to more mental health problems in terms of these symptoms? And again, we included neighborhood identity in this model, but in a slightly different way. So given what we knew from the first study about how feeling like you belong can bolster esteem, we wanted to see whether neighborhood identity might act as a resilience factor and if it was the case that financial stress led to lower self-esteem, could feeling like you belonged to your community help protect your self-esteem in that particular situation? And so we did find this mediated effect where financial stress led to lower self-esteem and higher levels of all three mental health symptoms. But when we included neighborhood identity here in the model, we found that it actually disrupted this pathway from financial stress to low self-esteem. So basically that relationship, that mediated relationship that we found disappeared. So for people who had low levels of neighborhood identity, who didn't feel like they belonged to their local community, for them financial stress led to significantly lower self-esteem and significantly higher levels of mental health problems. For people who had strong neighborhood identity, who felt like they belonged to their local area, there was no mediated relationship from financial stress to self-esteem to more mental health problems. And so it did appear that neighborhood identity could help buffer people from the negative effects of financial stress. And again, talk about implications of this. Obviously, what we would ideally do is look at the root cause of the problem and target this area of the pathway and minimize people's financial stress. But whether if there's political or practical constraints to that, another factor that may help is bolstering community belonging to provide resilience for people. And so I'm also going to talk about some work that we currently have in progress, looking at data from wave 2 of this survey, which included some specific measures of social identity, not just belonging. So looking at how much people incorporate their local community into self, but also some psychological and behavioral measures of self-harm as well. And so this is work that's being co-led by Peter Taylor as well from the University of Manchester. And we are currently looking at whether disadvantage can increase people's risk of self-harm, whether identifying with your neighborhood is associated with a lower risk of self-harm, both self-harm thoughts and self-harm behaviors. And again, we're going to test this buffering or resilience relationship to see whether neighborhood identity might attenuate the effects or reduce the effects of disadvantage on self-harm thoughts and self-harm behaviors. So the take-home messages, I'd like you to remember that people living in disadvantaged neighborhoods are experiencing increasing levels of poverty and mental health difficulties relative to advantaged neighborhoods, that financial hardship is associated with lower self-esteem and also worse mental health symptoms, and that feeling like you belong to your neighborhood is associated with higher self-esteem and seems to disrupt the pathway from disadvantage to mental health symptoms. That's all I have. Thank you very much. Are there any questions?
Thank you very much, Jason. Really interesting. And you do have quite a lot of comments and questions already in the chat box, which is great. So one of the first questions, which has been a little bit discussed already, but maybe you want to reply to it as well, from Peter Lloyd. How was local area defined for belonging and identity?
Yes, it's a good question. It was described as, I think it was your local street or area, or local street or block, I think. So yeah, so basically, you could probably think of it in terms of your postcode.
Okay, yeah. And a question from Justine Shenton. Do you also consider how mental health problems can lead to employment problems and financial stress? So it might be a circular relationship.
Yes, and I can't remember if I touched on that. I hopefully touched on that a little bit about the reverse causality in these relationships. So we know from previous research that it's likely that identity does causally lead to higher self-esteem, and self-esteem is causally linked to depression. But there's also evidence that you could reverse the arrows in this pathway, and that mental health problems can lead to self-esteem issues and make it harder to feel like you belong. But also, as your mental health problems can also lead to financial hardship and financial issues as well. So yes, probably this diagram is a better one to use. That the pathway could and likely does go in the other direction as well. So there's evidence for both causal pathways. And who was it? Sorry, that said that.
I think it was Justine Shenton.
Justine is correct in that the relationship we believe is going to be cyclical, which again is very problematic if you've got financial stress leading to these psychological problems, but then the psychological problems leading to potentially worse financial hardship and lack of belonging as well. So yes, it's the cycle that's particularly problematic.
Yeah, okay. And a question from Nefin, how does this link with the idea of social capital?
Well, I think belonging is part of social capital, isn't it? We didn't look at sort of the broad concept of social capital in these particular studies, but I think that it's sort of part of the social capital picture. Belonging is linked to things like social support as well. So yeah, I think it forms part of that picture. But yes, we didn't sort of look at social capital as a concept. We belonging and identity.
Yeah. Okay, there's two more things coming in. One from Ian Jarman, was personal support network measured, explored, which neighborhood could form part of it?
Sorry, can you say that again?
Was personal support network measured, explored? I think I can answer that as well, actually, because I'm giving a talk about this in a few talks time about personal support and neighborhood support in older people. So yes, we did measure that. Just one more comment or question, Jason from Pamela. Too many health professionals set people up for failure by telling them to do things they have no capacity to do, like smoking cessation. How do we impact on training to change this? Is this something you might be able to answer, Jason? It's the last comment in the chat box.
I'd love to, but no.
No, I don't think so.
No, that's a very good question. I think it's a very difficult question to answer. And it's, I think it's relevant, but I think it's difficult to answer with things like the Household Health Survey. I think it's really important and relevant. How do we use these findings on things like changing behavior or community belonging or social prescribing, and how are those things kind of treated and discussed by health professionals, and are they taking into account people's circumstances? Are they taking into account their social circumstances and financial circumstances? So yes, I think it's a really important question, but yeah, how do we change this? I don't have that answer right now for you.
Okay, thank you. That was great. Thank you very much, Jason. And if anyone still has any questions, maybe just drop Jason an email about it. So I'm mindful we've got a few minutes of a comfort break now. So if we all come back around, well, in 4 or 5 minutes time, 20-ish past, okay, time to make a cup of tea. Okay, see you then. So hi everyone again. Hope you've all had a little bit of a break. And next one up, we've got Helen Mulholland. I can see you there, nice to see you. And Helen will be giving a talk on socioeconomic and health determinants of suicidal ideation. So Helen, you should be able to share your screen.
Brilliant, thanks Clarissa. Can everyone see these slides? Brilliant, thanks. Thanks, Clarissa. Yeah, my name's Helen Mulholland. I'm part of the ARISE research group, which is the collaboration between the University of Liverpool and Merseycare NHS Foundation Trust. And as Clarissa mentioned, my talk is going to be looking at the individual socioeconomic and health determinants of suicide ideation using the Household Health Survey. So a bit of background information first of all. In terms of suicide ideation prevalence, approximately 9% of people across all cultures will experience suicidal thoughts, known as suicidal ideation, at some point in their lifetime. About a third of these people will plan their suicide, and over half of people with a plan will actually attempt suicide. And the personal impact of suicidal ideation has been likened to having severe asthma or alcohol dependence. So despite this significant disease burden, only just over a third of people actually receive formal support. And the key reasons for this don't tend to be around structural factors such as treatment availability. It's more in terms of a low perceived need for treatment and a personal preference for dealing with these issues on a personal level without any formal management. And these preferences might be suggestive of historical stigma about mental health broadly and suicide particularly. Now, these stats that I've shared with you are from the World Health Organization World Mental Health Survey, and they actually exclude the UK, and lifetime prevalence in the UK has been suggested to be more than double the global prevalence. So a significant issue. Researchers focused on identifying largely risk factors, more recently protective factors, but predominantly risk factors. And they have included female gender, parent psychopathology, childhood adversity, and the presence of diagnosed mental disorder and psychiatric comorbidity. But this research has been challenged for having a quite narrow focus and an individual focus, and not taking on board social, cultural, environmental factors such as relative inequalities and relational matters. So there was a systematic review of reviews undertaken by McClatchy and colleagues post 2007, and they tried to get a broader kind of remit of factors that might be impacting on the development of suicidal ideation. And they included the likes of abuse, internet use, sexuality, unemployment, particular occupations, and environmental factors as well. But the problem with this study was that it didn't differentiate between suicidalation and suicide behaviours. That distinction between ideation behaviours is kind of reflects the ideation to action theories of suicide, and one of those theoretical perspectives is this integrated motivational volitional model of suicide behaviour by Rory O'Connor and colleagues. So they suggest that there's an interplay between individual biopsychosocial impacts and factors that can lead a person to feel trapped, defeated and humiliated. And these feelings of defeat and humiliation endure when people feel that they don't necessarily maybe have the personal agency or resilience or motivation to overcome these issues, or that they don't feel supported by others, or indeed feel a burden to others, or that they feel that there's just no way out of their social or environmental circumstances. And this kind of enduring entrapment and a lack of escape can lead to the development of suicidal ideation. Within this model, it shows that that doesn't necessarily translate to suicidal behaviour, and that certain other volitional moderators need to be in place or apparent or present before that transition from ideation to behaviour occurs. So our study was trying to encapsulate this more complex idea of the development of suicidal ideation, and we were using the Household Health Survey to undertake this. And the kind of uniqueness, definitely in terms of suicidation ideology, research, is the fact that it was a community-based population, and largely a lot of the research is based on clinical samples, and the time frame across a 2-week time scale is more unique. It tends to be longer time scales, and obviously all the measures were valid measures within the Household Health Survey. So our study is really focusing just on wave 1 data only. We are looking to progress this to incorporate wave 2 data and look at differences, but what I'm presenting today is specifically to do with wave 1 data. So overall, there were 4,319 people recruited between August 2015 and January 2016, with a response rate of 61%. And the sample comprised 43% men and 57% women, an age range of 18 to 95 years, and most people identified as white European ethnic backgrounds. As you can see on the right-hand side of the screen, these are all the factors and measures from the Household Health Survey that we used. So it was a subsample of the questions, the overall questions from the Household Health Survey, and they were chosen based on theory, as I've mentioned, existing research evidence, and also large consultation with our project team, which comprised clinicians, academics, and public advisors with lived experience. So because mental health symptoms can explain a large proportion of variance in suicidal ideation, we constructed 2 models. Model 1 excluded mental health symptoms, specifically depression, anxiety, and paranoia, and Model 2 included these mental health symptoms. And this enabled us to quantify the association with and the predictive power of each of the separate social and health factors with suicidal ideation, above and beyond the effects of mental health. So the models provide estimates of the odds ratio of suicidal ideation associated with each variable, while holding all other variables in the model constant. So we were using the question 9 of the PHQ-9 patient health questionnaire self-report measure, which stipulates over the last 2 weeks, how often have you been bothered by any of the following problems? And question 9 is thoughts that you would be better off dead or of hurting yourself in some way. And these are the responses to that question within the PHQ-9. So as you can see, 89% of respondents didn't confirm that they experienced suicidal ideation across the previous 2-week time frame. 11% did, and that's broken down, as you see, across several days, more than half the days, and nearly every day. So obviously that the information is highly skewed there, so we decided to dichotomize the variable so that we were coding people where suicidal ideation was absent as 0 and suicidal ideation present as 1 within the models. These are the results of the logistic regression for model 1, which excludes mental health variables. And we're showing here the risk and protective factors that were statistically significant. So as you can see, younger age, in particular those aged 18 to 24, younger age had the greatest impact in terms of odds in relation to suicidal ideation. And similarly, in terms of protective factors, empathy reduced the odds by the greatest amount. So I won't go through all of them, but you can see the array of risk and protective factors there. And possibly one of the surprising ones and unexpected ones from the study was having arthritis, but I'll touch on that later. This is a graphical presentation of that information. And so you can see kind of the quantification of those odds. And as you can see on the far left-hand column is younger age, and that's having the greatest influence. And also what this graph shows is that the risk factors have a somewhat greater impact in terms of odds of suicidal ideation than do the protective factors. These are the results for model 2, which is excluding mental health variables. There are fewer risk and protective factors identified here. And all the mental health factors, depression, anxiety and paranoia are found to be risk factors for suicidal ideation, and the greatest impact being depression. Again, some of the other aspects, identifying as lesbian, gay, bisexual, transsexual or queer, being in the same financial position as the previous year, being Black and ethnic minority status. And again, empathy was the greatest protector, abstaining from alcohol, and having arthritis was stable across both models. So again, there's a graphical presentation of that information there, and we can see depression having quite a significant influence in comparison to the others, and empathy as a risk factor there, as a protective factor rather, sorry. So in terms of interpreting these results, I'm definitely thinking about what Jason was talking about in his previous talk, and also in relation to the theoretical model that I shared with you earlier. The idea really that these risk factors can generate feelings of burdensomeness, defeat, entrapment, psychological pain, physiological pain, hopelessness that people feel defeated and humiliated with. And trapped within, hence, their sort of development through to suicidal ideation. And similarly, the protective factors could buffer and increase support, reduce stigma. In terms of the unexpected finding of arthritis, potentially there is antidepressant effects of medication, but obviously this is all supposition and would require further investigation. But it could also be that people with arthritis, it's kind of a more common problem, people are more aware of it, there's broader social networks, people are less more inclined to disclose their issues with arthritis, and then get and seek that support, and there's more information about it potentially. And this is the same for the other factors that we've identified as well. Some of the factors that we identified in terms of poor quality housing, static financial position, being unemployed, represent, the health inequalities that we're all aware of. Younger age, as I've mentioned, and sense of hopelessness, and believing your life to be determined by chance, kind of taking away that kind of personal agency and control, and including developing thoughts of defeat and entrapment, really. And similarly with social connected factors as well, a sense of maybe thought of belonging, and that may come from discrimination or social exclusion. And conversely, protective factors could engender connectedness and a sense of belonging. Empathy was a protective factor as well, and there is some evidence to suggest that this may be a social deterrent. If you kind of have a greater understanding of perspective taking, you might appreciate other people's point of view from, you know, your thoughts of suicide and where that may lead and the impacts on people as well. And it might be a cultural or religious kind of deterrent as well from that perspective. As we mentioned, people have a preference for dealing with suicidal ideation personally rather than seeking more formal support. And so they may use alcohol and smoking as kind of coping mechanisms, which potentially are ineffective and mask rather than deal with issues. So there's some strengths and limitations to this study. Obviously, there's a dearth of research that uses a broad spectrum of factors, and we've tried to address that gap in the literature. This study is based on a community sample rather than a clinical sample, which is definitely unusual in suicidology research, and the shorter measurement time frame of 2 weeks is more in keeping with clinical practice. It's based on valid measures, and it was a large representative sample. But the measures, it was self-report methods, and obviously the sensitive nature of the question, there could be some reporting bias. It was a single item out of an overall measure, and it was a regional rather than national survey. Also, we are purely looking at suicidal ideation rather than suicidal behaviour, and as we've noticed in the theory of suicide, there is a distinction between the two. And there was many more people who didn't experience suicidal ideation within this population, and so the variable was particularly skewed. In terms of clinical implications, our findings support a public health approach to intervention, including social prescribing. So we're advocating peer support and neighbourhood support groups for particular groups that will really promote social support, reasons for living and continuing, a source of perspective taking as well, as we've mentioned, and a buffer really in line with the motivational moderators that were identified in Rory O'Connor's model. The whole purpose of research from a very personal perspective is to try and have a positive influence on clinical practice and knowledge, and ultimately positively affect people's lives. And we're hoping that by identifying new risk and protective factors, we're adding to that conversation. And the methodology that we've used, we've tried to ensure that our findings are as generalizable as possible. So the study suggests that it could be useful to increase community belonging, in a similar vein to Jason's previous talk, and that increase in empathetic functioning could be potentially beneficial as well. So this is not work that I've done alone, this is the team, and although half of the team were involved in publication that is there, the team is broader than that, and we'd like to thank all of the people within the team.
Great, thank you very much, Helen.
Thanks.
Thank you, that was interesting. I'm mindful we only have time for about a question or so. And I noticed that Rhiannon and Jason have already answered some of those questions as well in the chat box, which is great. So Helen, question from Nefin. His question is just, why is arthritis protective?
Well, it was a surprising finding, definitely, and the answer is we don't know. We're suggesting, as I mentioned, that it might be that there's less stigma about arthritis and people share their thoughts more about it, and so have a broader understanding of their condition and how to deal with it, and social support to support that, but also potentially that some medication may have potential antidepressant effects, but that's all conjecture really, and would need verification.
And just to add to that, sorry, it could just be a statistical artifact. We looked at lots of predictors in the model, so it's possible it's just a type 1 error as well. But I think the reasons that Helen provided also valid. But yes, any of those.
Thanks, Jason.
Yeah, and just one quick question from Justine. Helen, do you think empathy could be translated as meaning or purpose?
I suppose. I mean, again, it's all conjecture. You're very limited. You can't ask anybody, additional questions beyond the responses that they've given in the survey. But it could give people purpose and meaning, having greater empathy. Again, it's conjecture.
Okay, thank you so much. And then there are a few more comments if you want to look at the chat box as well, Helen. Great, thank you. So, bit weird, but now I'm giving a talk, so
that's all right. I'll chair your bit.
Okay. Good. So I'm just going to share my screen. So here we go. So I'm going to talk a little bit about an analysis we've done specifically looking at the older adult population in the HHS survey. And we've looked at social support in older adults and healthcare utilization. So a bit about background. So I'm just going to move this. There we go. So social isolation and loneliness is unfortunately really, really common in older adults. And when we talk about older adults, obviously this depends by country as well. So in high-income countries, older adults, we mean aged 65 and above. For example, in lower and middle income countries, older adults are classed as aged 60 plus. So a recent survey shows that in the UK, around 32% of older adults are living alone, and 2/3 of them are women. And a survey done by a charity has also found that about 1 million people aged 75 and above in England go for over a month without speaking to anyone. So this has been pre-pandemic already. So this has been a huge issue before the pandemic. Now throw the pandemic and social restrictions into the mix, and I'm sure all of us have faced some levels of social isolation and loneliness from our friends, family, our networks, hobbies, etc. But this is just an added pressure and added difficulty to already quite socially isolated and lonely older adults. Okay, so just a couple of pictures to kind of showcase that a little bit, how it is in the pandemic. And I'm going to refer back to this after I'll be talking about the HHS findings and put it into context of the pandemic as well. So what have we done? Bit of background in terms of social support, and I know there was a question earlier as well, I think it was to Jason, about what is social support and personal social support. So when we talk about social support, this can mean being linked up with your community, with your neighborhood. It can mean getting that support from your friends and family, but it can also mean accessing social support services. And these are very common for older adults, including those who live with dementia or cognitive impairment. And social support services can be, for example, daycare centers or peer support groups or social activities in the community, such as singing and dancing groups or walking groups. Anything really that connects you socially to peers and gives you a bit of support. Okay. So in the HHS, we asked a number of questions and statements for participants to rate in terms of social support. So here you see all of those that we asked. For example, people were asked, how often do you meet up with family members or friends? And then participants were asked to rate this on a Likert scale from 1 to 5. So 1 meaning not likely at all, 5 meaning very likely all the time, for example. So for our analysis, we thought, that's a few too many variables to understand social support. We want ideally one single variable to then conduct some analysis and regression models with that. So what we've done is a principal component analysis. And what this did was it helped us identify which of those initial 9 statements on social support could be merged into one variable. So when we did the principal component analysis, there were 3 separate variables identified, which had what we call an eigenvalue higher than 1. So that means they're a good variable. But some of them focused on personal social support, and these are the 3 comments you see on the screen now. And then there was some on neighborhood support as well. And we thought for this particular analysis, we're really interested in how older adults are personally receiving that support, not necessarily how they are supported by their neighborhoods. So that means we kind of merged those 3 statements into a variable of personal social support for our analysis. So here's a bit of a diagram on how we selected those cases from the overall HHS. So as Ben was saying earlier as well, so we had over 7,700 participants or cases, both in wave 1 and wave 2, all aged 18 plus. 2,000 of them were aged 65 and above, so we included them. Then we excluded a few more because some of these participants had been interviewed both in wave 1 and wave 2, but we only wanted those that had been interviewed, we only wanted one time point of interview. In the end, we also excluded some cases because they had very high GP or A&E attendance, and those were outliers really. They would have kind of biased our results, so we excluded them. So in the end, we had 1,685 participants that were included in our sample. So what did we do with that then? So we had the population, and we did some Poisson regression modeling, and I'll go through this slide now. So as opposed to just looking at how social support is linked to GP visits, GP attendance in older adults, we also included a few other variables because it's not just one factor that is linked to GP visits, but we also wanted to understand how is depression, how is frailty, distance to your GP surgery, as well as education and socioeconomic deprivation. How are all these variables linked to older people accessing their GPs? So higher levels of deprivation were linked to higher levels of GP visits. So the higher your depression, you have a 3% higher likelihood of seeing your GP. If you are moderately frail or severely frail, then you are much more likely of seeing your GP. Indeed, 69% more likely than if you were not frail. And then we also did the distance measuring. So for each 1 kilometer of GP distance to your GP surgery, you are 7% more likely to access your GP if you're an older adult in that sample population. Now, on the other hand, we also found factors that were linked to lower GP attendance. And obviously the one we're really interested in was the social support. So older adults that had higher levels of social support were 6% less likely to see their GP. Those with an educational qualification, as opposed to no qualification at all, were 7% less likely. And those living in IMD quintile 2, compared to 5, were 13% less likely. And just to kind of go back to what the IMD quintile stand for, quintile 1 means the least disadvantaged neighborhoods, and quintile 5 means the most disadvantaged neighborhoods. So as I just mentioned, it's really that social support that we were interested in. And it's a really interesting finding showing how well you are connected, how well you're linked up with family members, friends, social services. That actually is linked to your healthcare utilization. And that also suggests there might be a call for improved social prescribing, for example, because this is really one way in which GP attendance could be reduced in older adults. But what's the impact of COVID? So as I just mentioned earlier, older adults had already been socially isolated, lonely. As a result of that, it often leads to depression as well, sadly. So what's the impact of COVID? We are faced with now lockdown 3 for over a year, different lockdowns, different social distancing measures. Services are being shut down. We're not able to see our family and friends. So I'm going to talk a little bit about a study we've done last year on the impact of the pandemic on social support services for older people with and without dementia. And we've done a 2-part study. We've done a longitudinal survey from April through to August at 3 time points, and both via telephone and via by the internet. We asked older adults with and without dementia and unpaid carers, so family members and friends, about the impact of the pandemic on their social support service usage. So as I mentioned earlier, social support services can be daycare centers, paid home care, befriending services coming into your home, all these different things. How has that been impacted at those 3 time points, and how was it before the pandemic? But what we also asked people at each time point was about their levels of mental well-being and mental health. So we asked about anxiety, depression, for example. And we had roughly 400 people who completed all those 3 time points. Now, to complement that, we also conducted baseline and follow-up interviews, baseline in April and follow-up interviews in June and July. So we had over 70 interviews of participants back then. And the qualitative findings support the quantitative findings, but in this next couple of slides, I'm just going to give a really brief snapshot of what our survey has shown. So here you can see on this slide, you can see service usage by time point. So in this particular figure, we've merged all participants together. So that's older adults with and without dementia and unpaid carers. And we've particularly highlighted those social support services that had been used to the greatest extent pre-pandemic. So in the very light gray arrow bar, you see the situation before the pandemic. And then you also see how it was at time point 1, 2, and 3. So April time, June time, and August time. And all of them have significantly dropped. The only services that seem to have started to go a little bit up again throughout that trajectory of the study were paid home carers and support groups. And our qualitative findings have highlighted that as well in terms of paid carers, that whilst many family members were really afraid of the virus, they still wanted to continue people coming in to provide that social support to their elderly relative. And in terms of the support group slight increase again throughout the pandemic, it seems to be that support groups have adapted to providing remote support and remote delivery. So for example, via Zoom, via WhatsApp, via Skype, etc. But as you can see, the other types of social support services which are vital, daycare, befrienders, social activities, they remain low and they haven't reached pre-pandemic levels anymore. And just to link that up, these findings from our survey, we looked at how reductions in social support service usage were linked to levels of anxiety and levels of mental well-being. And what we found was that reductions in support service usage between pre-pandemic and time point 1, so around April time, were linked to higher levels of anxiety in older people with dementia and older adults without dementia. They were also linked to reduced levels of mental well-being in unpaid carers and older adults without dementia. So it clearly highlights that social support and engaging socially, it's important for people's mental health. And just to kind of wrap up this talk, I'm not sure whether you've seen this on the BBC News recently. There was a report out from a charity saying that the health of 28% needing social care has dropped during the pandemic. Now, this is not only older adults who are in need of social care, this is anyone, any age group, but it really shows how vital social support and social care is to anyone, and also how that impacts on people's health. And hopefully, well, the pandemic has highlighted really a detrimental impact on social care, but there should be a wake-up call that social care and social support needs to have much better support to really support older people better and their health. And that's my talk.
Very much. Well, I can't see any questions apart. Oh, right. So something around adult children from Steph, which I think was a comment on what you were saying there, Clarissa. And there is a question here from Pooja. Was there a difference within different populations on wanting to provide support to family members, e.g. ethnicity? And I guess my recollection of this survey was the BAME numbers were actually very small relatively.
They were really low, Pooja, and also in our qualitative study, sadly, we tried to specifically approach minority ethnic groups, but they were quite hard to reach and engage with both of those studies.
Yeah, we found the same problem with the Muslim study that Shema Hassan did in Liverpool in depth, trying to recruit older Muslim adults proved extremely difficult. Okay, paid carer increase matches growth in numbers of providers, low barriers to entry, issue of quality. That's very brief, Peter. That's from Peter Lloyd. I'm trying to make sense. Can you address that one? So is that, I think that's a comment really.
It chopped me off.
You want to just say what you were asking then? Right.
Let me just unmute. Can you hear me now?
Yeah.
Okay. It chopped me off. The chat had gone on the bottom of the page, so I chopped it off. I've been working on the supply side here. I've virtually written, as Clarissa knows, a paper on the supply side of this from the point of view of social care. The first point is that one of those surprising findings, like arthritis in the previous one, is that whatever else is happening, the number of domiciliary care providers has recently gone up. What worries me about that is you can get into that real easy. You can just get out there and do it. And I'm worried about the sort of quality at which that's being done, while relatives are wanting to pay for somebody where they can't go to support them. So that's the first point. But what all the evidence is, and I talked to the network here last week, is that domiciliary care is on the verge of collapse in the poorest areas where they cannot get top-ups from those who can afford self-payment care. This is a huge crisis that's about to hit us once the system begins to kick in again. It's virtually collapsed. It's no damn good at all for the government in the review to say, we'll sort out the NHS first and we'll think about social care later. I'm really angry about that.
Thanks, thanks, Peter. That's very interesting. And if anyone wants to see what Peter's writing, please go on to our website. Peter and a colleague of his has written a number of very interesting linked monographs about the pandemic from the beginning, addressing a whole load of health inequalities and other social issues. Yes, and I think, and Steph's pointing out that if we lose the social care package, once it's gone, it's very difficult to get back. And I think that's something that, Clarissa, you found in your study, wasn't it? That people were holding on, even though they were anxious about people coming into the house. Their fear was that if they stopped them coming, they'd never get them back.
Yeah, precisely. That's what we found in our qualitative work. So people from more disadvantaged backgrounds were really reliant on that financial support to get that social care package of paid home carers coming in. They obviously needed that, but they were also so concerned about virus transmission. But they thought, if I stop paid care now, I will never get it back after the pandemic. So they lived with that fear of having paid carers coming in.
Okay, so I'll let you take back the chair, Clarissa. I think that's the end of the questions.
Yeah, thank you. And next up, we've got Professor Rhiannon Corcoran, and her talk will look at examining neighborhood determinants of mental health and well-being using network analysis. Right, Rhiannon?
Yeah, hi everybody. Can you see my screen?
Yeah.
Lovely. So thanks, Clarissa, for chairing this and for doing such a great job pulling it together. I'm very grateful to you for that. And it's lovely to see some friendly, familiar faces in the audience, as well as some new people. So thanks for coming along today to celebrate the work that we've done as part of the Household Health Survey. So my talk today is going to be looking at neighbourhood determinants of mental health and well-being, and it's using a particular way of analysing data, which is called network analysis, which I'll briefly explain during the talk. But before I do that, I just want to acknowledge my co-authors here. So as Mark was emphasising, the Clark and the ARC are collaborations, and so all of these papers have a number of collaborators, not just in academia, but in local authorities, in healthcare trusts, and also very importantly, our public advisors. So all of them are represented in these particular papers that I'm going to be talking about now. The first paper looks at mental health as measured using continuum measures of mental health. So it looks at particular symptoms that might be related to mental distress. And it's published in Clinical Psychological Science. And then the second one is looking more at subjective well-being. So it's a network analysis looking at individual and the place factors that might be associated with people's self-reported subjective well-being, and that's not published yet. It's in review with BMC Public Health, and we're hoping that it will come out quite soon. So I'm just going to cover briefly the basics of network analysis. You don't need to know the ins and outs of this approach, but you do need to know certain things to be able to understand the diagrams that I'm about to show you. So first of all, I think it's important to acknowledge that the complexity of the interactions between social and physical neighbourhood environments and individual differences in mental health and well-being really does need quite a sophisticated analysis approach so that it can capture both very complex, interrelated, direct and indirect relationships that exist between these particular, if you like, clusters of variables. And what network analysis does is it does that. It captures those direct and indirect relationships, and it acknowledges the way they might be related to other relationships within and between clusters of variables. And so network analysis is driven by the relationships within the data that you're looking at. And for us, we were interested in considering the within cluster relationships for mental health and well-being as a complex network of associated symptoms. And that's important because we weren't, as a group, particularly interested in whether or not people were diagnosed with depression or anxiety. We were interested in the extent to which they reported symptoms of distress, if you like. And what network analysis does is it uses graphic representations of what they call nodes, which are really just the variables, the things that are being measured, the items in the questionnaires, for example. And then it also represents what they call edges. And these are the lines that link the nodes or the variables to show the connections between them. And this enables us to look at relationships between nodes or variables, both within clusters like mental health measures and across clusters like from mental health variables into more neighbourhood variables like social and physical aspects of the neighbourhood. And so here in particular, we're interested, as I've said, in mental health or well-being and neighbourhood factors, which can be either social neighbourhood factors related to community and physical neighbourhood factors such as the infrastructure and the assets that certain neighbourhoods might have. And this data that I'm going to show you today is the wave one of the Clark Northwest Coast Household Health Survey data. So it's just wave 1 that I'm showing you in these analyses. So what are the aims and objectives of the analysis that I'm going to show you? So one of the things we really wanted to identify was what are the specific bridges, in other words, bridging nodes or variables that link the mental health symptom cluster, like depression, anxiety, and paranoia in particular here, to and from the neighbourhood social environment clusters. So what are those particularly strong bridges that link between mental health variables and neighbourhood social variables? We wanted, of course, to take deprivation into account when exploring the association between mental health and neighbourhood social environment, and we expected there to be more and stronger connections between the mental health clusters and the neighbourhood social environment cluster in disadvantaged neighbourhoods. Jason has already shown us that that came out in some analysis, just looking at the total scores on the measures that we used. And so we fully expected to see that. But what we wanted to investigate with this analysis were the extent to which certain symptoms might be associated with neighbourhood disadvantage more than others. We wanted to examine the links between well-being, which is sort of positive mental health, so feeling good and functioning well, and neighbourhood characteristics, and also to look at their interrelationships with individual factors, so things to do with the individual themselves rather than necessarily to do with where they lived, although that's a moot point, I think. And then we wanted to identify the individual and living environment characteristics that were most strongly associated with overall well-being score, and importantly in this analysis, with the single questions, the single items within the well-being measure that we use, which was the short Warwick-Edinburgh mental well-being scale. And the reason that's important is because subjective well-being is made up of a whole host of different things that you can measure, in this case using a questionnaire, and they run from things like feeling that your life feels worthwhile, to feeling optimistic, to being happy, all sorts of different things that might relate very differently to different neighbourhood and individual factors. And what's important to say about these particular aims and objectives and the research that we've done because of the Household Health Survey is that we were able to use this innovative way to look at the interrelationships in a way that's never been done before. So this is really new stuff. So onto the variables of mental health. So on this slide, you can see the network analysis, which looks at the relationships between and within clusters. So I'm just going to spend some time going through this. So you can see a cluster here of orange nodes. They are the items on the PHQ-9, the measure of depression that we used. And each of those nodes represents one question on the PHQ-9. So, for example, Helen talked about suicidal ideation, suicidal thinking. So that's represented here on this node. And there are different questions, obviously 9 that are used to measure depression in this item. In the sort of mustard yellow colour, there is a cluster of nodes related to general anxiety. So that's the GAD-7 measure that we used. So it includes things like worry, irritability, nervousness, fear, etc. All the associated symptoms of generalized anxiety. And then another mental health cluster is that of paranoia. So it's in green here. And this is a measure that we devised a number of years ago to look at feelings of persecution. So it includes 5 items here that we used in the survey. Feeling suspicious of other people, feeling that you can only rely on yourself, worried that you've been deceived or lied to, those kinds of items. And then below these are a couple of questions that we used around hearing voices, which again, Jason has talked about already. And then moving across the diagram, the items in blue here are social connectivity items. So whether or not somebody lives alone, or whether they feel that they have people they can call on for help, and whether they have people to call on for company. So they're in blue there. Neighbourhood cohesion, these items here is how we measured neighbourhood cohesion, and they are in this purple or lilac colour. So looking at feeling of belonging, which Jason talked a lot about, and which we've heard quite a fair bit about in the presentations before. Feeling that we could, we have trust in our neighbours. Could we give our neighbours our spare key, for example? And that people will look out for each other, and that also here within neighbourhood cohesion, can we influence local decisions? And then finally, this cluster up here in pink is a cluster of neighbourhood disorder. So people drunk and rowdy in public in your area, rubbish, litter, vandalism, harassment of minorities, and teenagers hanging around, troublesome neighbours, that kind of thing. So indicators of neighbourhood disorder. So those are the variables within the mental health paper. And I'm going to show you the next diagram, which is what I want to emphasize here, is that we were able, because of the size of the sample, to break it down and conduct separate network analysis for neighbourhoods which were low deprivation neighbourhoods, what we called our low deprivation comparator areas. And then we also looked at moderate deprivation and high deprivation. So this doesn't really relate to the neighbourhoods for learning and the comparator areas, but it turned out that there were some areas that were moderately deprived versus some that were more highly deprived. And that enabled us to take a much more nuanced look using this kind of analysis at the relationships across the clusters here, and in particular in relation to these neighbourhood factors and their relationships and interrelationships with mental health continuum measures that we had. And so what's important to draw out from this slide is that when you look at the low deprived neighbourhoods, you see absolutely no connections across the clusters. Okay, so when you live in a fairly wealthy, comfortable area, where you live doesn't impact upon your mental health and well-being. You're quite happy there, everything's okay. You might have mental health difficulties, but they're not exacerbated or related to your own particular neighbourhood environment. When you move to moderate deprivation, you begin to see one connection. It's not particularly strong, but one connection between, it is significant but not particularly strong, between this node in anxiety, which is irritability, and this one here, which is about teenagers hanging around your area. So people will find teenagers hanging around a little bit irritable, and that irritability will stem into other clusters of anxiety, nodes of anxiety there, but nothing much. And then when you move into the higher deprivation area, this network analysis shows that there are more connections from, this time, not anxiety, and I think this is important, instead paranoia. So individual nodes within the paranoia cluster are connected up to social cohesion in particular, but also to social disorder, as I'll summarize in the next slide. So you're seeing a difference from the moderate neighborhood. Sorry, I seem to have skipped a slide there. I'll go back to this one. Between the moderate deprivation neighborhood and its relationship with neighborhood disorder to anxiety, to move towards feeling more paranoid or persecuted in the high deprivation area, and linking to different nodes within different clusters. So something is going on there that makes that change happen. So just to overview those findings on mental health, So paranoia, especially being suspicious of others' intentions, has a strong bridging role to neighbourhood social environment. So it is one of these bridging nodes that we were interested in. So being suspicious of others' intentions is a strong bridging node. It has 2 positive links with social disorder. And what that means is that as social disorder goes up, so does paranoia. And 4 negative links with social cohesion. So in other words, as paranoia goes up, social cohesion goes down, so they go in different directions. And what's been picked up already in the chat, which is really important, is that these relationships are likely to be bidirectional, they're likely to be circular, and they're likely also to spiral as conditions get worse. In relation to anxiety, so that was also negatively connected with social cohesion. So in other words, as anxiety goes up, it'll be in the context of low social cohesion. And again, that is likely to be bidirectional, but the data and the way we analysed it, we can't show that using this particular analysis. So neighbourhood social environment is not, and I think this is important, directly linked in our data at least to depression or to hallucination proneness. It is linked through anxiety, and as you go up to look at more disadvantaged neighbourhoods, it's linked in particular through paranoia. Importantly as well, the social connectivity cluster didn't seem to be directly linked to any symptoms of mental distress. It was the social disorder and the social cohesion clusters which were the important ones in this data. And there were more significant bridges between mental health and neighbourhood social environment in our disadvantaged areas, as you saw from the last diagram. So that's a summary of the mental health continuum measure analysis that we did. I'm going to move on now to think about the well-being analysis that we did. So here is another network analysis using the same data set. I'll just go through this quickly. So in pink up here is the total score on our well-being measures. So this is just looking at well-being as a construct in this first network. And then in this sort of light yellow colour, we have what we called our individual factor variables. So they include things like your health, your finance, home ownership, whether you're married, whether you're employed, your educational level, that kind of stuff, including religiosity and care and support. And then in the lighter blue colour, we have the neighbourhood or place-based variables. So they include things like neighbourhood cohesion and disorder, as we saw last time, civic engagement, use of open and green spaces, that kind of thing. Now, although it's not important for you to understand this, I imagine somebody is going to be asking, what do the different shapes mean here? So the shapes are to do with how we measured those particular variables. So you'll notice here with the club, which is the membership of clubs in your area, it's a triangle because that was a count variable. So it's just a number variable, whereas most of them are circles and they're continuous variables. So they're measured along a scale of things. So I'm going to move on now to to look at the network between.
Rhiannon, I'm mindful of time. It's we only have 1 minute for questions now for your talk. If you could just really quickly wrap up, that'd be great.
Wrap up, yeah. So these are the individual items on the wellbeing scale in pink here, and their relationships to the different individual factors and neighbourhood factors. So you'll see it's a very dense network. There's lots of interconnections between these things, and they're both negative and positive in red and blue in terms of the edges or the links. So the overview of findings for wellbeing then. The overall wellbeing network, there was 47% of nodes directly connected, and that illustrates the diverse and complex pathways between wellbeing, individual factors and neighbourhood characteristics. It's true that individual factors were more related to subjective well-being than neighbourhood factors, but neighbourhood variables were positively associated with well-being, and in particular, local green or open space usage, civic agency and neighbourhood cohesion were important to subjective well-being. And neighbourhood and well-being was also associated with housing disrepair, which I think Ben mentioned before. And in relation to the individual well-being questions, I've been feeling close to other people was associated with particular questions. So particularly neighbourhood cohesion, and civic agency was associated with the item I've been feeling optimistic about the future. And green space usage was positively associated with both of those items. So you can begin to become more nuanced about what types of well-being are related to what particular assets. Quickly then, on remaining gaps and issues, I talked about bidirectionality, and we need to be able to look at this more thoroughly, and we can achieve this by looking at the sample who had tested twice in wave 2. And then finally, recommendations. So we clearly need to conduct some replication, but most importantly here, that mental health and well-being inequalities in part arise and are sustained because we live in unequal places, and we need to be able to explore the tipping point. So when do negative aspects of physical and social environment begin to be intolerable for our mental health and well-being? And that's me.
Great, thank you very much. Thank you for that presentation, Rhiannon. I'm mindful of time and that we all need a bit of a lunch break probably, but Rhiannon will be chairing a breakout room shortly after the lunch break on mental health, and we'll have a chat about that afterwards. So maybe we can take questions then, Rhiannon, about it?
Yeah, sure.
Yeah. So now we've got about 20 minutes of a lunch break, and then we've got one more talk by Dr. Pooja Saini. And then we have some breakout room discussion, so you won't just hear us, but you can chat all amongst each other, a bit more engaging. So we'll see you all in 20 minutes time. Okay, thank you already for being here. Right, welcome back everyone. Hope people have had some lunch or stretched their legs. And next up, Pooja, do you want to share your screen?
Yep, I'll just do that now. Okay. So I'll just try and make it bigger. Is that okay?
Perfect.
Is mine showing two slides as well, or?
Nope.
Just one?
Just one.
Okay. Brilliant. Great. Okay, well, thanks again for organising, Clarissa. I think it's been a really interesting event. And there's been a lot of talks that are going to feed into this as well, which is fantastic. So I'm going to be speaking about a project that we worked on the social and mental health predictors of emergency department and general practitioner usage, using the household health survey data as well. I just wanted to highlight again, kind of our team members who are quite mixed, and we had 4 public advisors involved throughout, and other partners as well, which is fantastic. So I suppose, why is this important? Why do we need to look at this at all? So as we're all probably aware of, there's a high demand for emergency admissions, and it's a huge issue in England because of the rapidly increasing use of accident and emergency and general practices for mental health issues. And there's a huge cost associated with this, particularly for people who use accident and emergency and then may be admitted to hospital as well. So we wanted to focus on examining the social determinants of health service utilisation, specifically for people with mental health issues. I'm not going to talk too much about the methodology because I think I'm going to be repeating a lot of what other people have said, but I have got some slides ahead. So how does this work fit in with what's needed at the moment? So there is what's classed as an A&E crisis in England. I'm sure many of you are aware of the huge waiting lists as well, waiting times in A&E, which is a huge problem, and the usage and numbers. And as I've said before, it can be a huge burden financially on the NHS. Now, what has been shown previously is that there's links to health inequality as people living in more deprived areas use these services more. So we wanted to have a look at, our study and see, are we seeing the same type of things? Also, mental health patients are at risk of repeated hospital admissions and increased number of GP attendances. So again, we wanted to have a look at that and also look at the comparisons between GP usage and A&E usage for these groups. Another aspect is we've obviously built on the survey and used the data that was collected. So we asked people about their usage of services. So again, that'll come up in some other limitations later, but it was self-reported usage of the services when they were interviewed. And what we also know is that mental health comorbidities, so having more than one mental health condition or having mental health and physical health conditions, can increase the risk of attendances to both A&E and GPs. And what we found in this study, which we'll talk about in more detail, is that depression predicted both A&E and GP attendance, even when we adjusted for physical health and socioeconomic status. So we'll go into this in a lot more detail now. So as other people have already alluded to, this was conducted across 28 neighbourhoods. The questions, I think everyone has presented on the different aspects of the survey. We also used Poisson regression models to assess the effects of mental health comorbidity, mental and physical health comorbidity, and individual symptoms for mental health. And the symptoms we looked at were depression, anxiety, paranoia, and auditory verbal hallucinations, which again have come up in some of the previous presentations as being factors that are affecting people within the community. So we'll have a look at that against A&E and GP attendance. I also just wanted to highlight that people were reimbursed for their participation within this research. So again, you have been told this before, but just the numbers of the people recruited. So we only included the first wave data. This study was conducted earlier on, so we didn't have the second wave at that point. And the mean age was 49, and majority of the participants were white European ethnic background. So if we start to have a look at what we found, there's going to be 3 lots of areas I focus on now with the results. So the first one is reviewing A&E and GP usage among people with severe mental health symptoms. So what we can see here, similar to what Rhiannon was saying before, is that people were attending more for both A&E and GP, as well, with severe anxiety and auditory hallucinations. So that was higher within our sample as well. And you can obviously see that there's a lot more attendance within GP than there is within A&E settings. But for the individual severe mental health conditions, the numbers were higher than the mean for the total sample. So if we look at this data for other variables, sorry for it's a bit busy, but what we found to highlight, if we focus on the left of the slide, is that younger people aged 18 to 24 were associated with higher attendances at A&E and GP. Females were more likely to visit the GP. People with less qualifications were more associated with higher A&E attendance, which again was highlighted in some of the previous work. Unemployment was associated with higher A&E and GP attendance. Problems with housing were associated with higher A&E attendances. Living closer to A&E and GP practice was associated with higher A&E attendance. And problems with self-care, physical activities and pain were also associated with higher A&E and GP attendance for individuals with mental health symptoms. Depression was the only mental health symptom that was significantly associated with A&E attendance, and anxiety was the only symptom that was significantly associated with GP attendance. So there's some of the findings from that part of the analysis. Secondly, we looked at the relationship between physical and mental health comorbidity and service use. So what you can see here is as the number of conditions increased for people, they were more likely to attend A&E or at the GP, and the rates go up significantly higher as we go across the diagram. So people with 4 symptoms or more are attending a lot, but from what we can see is even people who have got 2 symptoms, the rates are very, very high compared to people with 1. So again, if we look at that in a bit more detail, we can see again, this was more of an issue with younger people, aged 18 to 24. This also affected ethnic minorities group more with physical and mental health comorbidities. But as we've alluded to before, only 11% of the sample were from ethnic minority populations. So I think we need to treat that quite cautiously. Unemployment again was, or unemployment actually this time was associated with higher attendance at both. Again, problems with housing. Moderate and heavy drinking was associated with higher GP attendance, but not to do with A&E attendance. And we have done some other work that hopefully will be published soon on drinking and A&E attendance too. Living closer to an A&E was associated with higher A&E attendance, and having only a mental health condition or 1 physical health condition was associated with a higher rate of both A&E and GP attendances. Again, comorbidity was associated with 4 times higher rate of A&E and GP attendance. So I think we can start to see that for people who've got multiple health problems, and even just having 2 health problems can significantly increase attendances at both GP and A&Es. So for the final group, we had a look at health service usage according to the number of severe mental health symptoms. So as I mentioned before, they were depression, anxiety, auditory hallucinations, and I'm just trying to think of the third one now. I've forgotten it. I'll see it in a minute. That we looked at. So again, you can see here that the rates of attendance increase the more symptoms people have, but it's even higher when you look at people with 3 symptoms for GP usage. So and it's still pretty high with 2. So it's increasing a lot. And I think there comes a point where if you've got 2 or more, you're just going to be significantly more likely to attend at either A&E or GP practices. So what do we find that was significant within this group? So when we're looking at mental health comorbidity alone, likely to attend both A&E and GP. People who are less qualified were associated with higher A&E attendance. Unemployment was associated with both A&E and GP attendance. Again, problems with housing, also living closer to A&E, and problems with self-care, physical activities and pain were associated with higher attendance to A&E and GP attendance. And finally, mental health comorbidity showed significance as well, with higher attendance at A&E and GP for people with 3 or more severe symptoms, mental health symptoms. So we've alluded to earlier the strengths and limitations of the study as well, but just to go over that again, that the fact that some of the strengths were a large data set, and the fact that this study was conducted across 28 neighbourhoods in the Northwest Coast. The data was self-reported survey data, so that needs to be taken cautiously. We used knock-on-the-door recruitment, and evening sampling was limited due to practical constraints, so we may have missed groups of people who were working, doing shift work, and things as well, who may have only been home in the evening. The survey was not able to capture the most disadvantaged groups in the population, such as homeless people and unregistered migrants. And as we're all aware, they could have made a significant number of our group as well. And we can't generalize this to other regions and populations necessarily for everywhere. So to conclude, and just a couple of other things I wanted to highlight before I finish really, we can see across the both groups that there's some things that are in common. So young age, unemployment, having problems with physical care, physical health conditions and comorbidities. We can also see some nuances there. So for people attending more A&E with severe depression, and people attending more in primary care with severe anxiety. So it makes you start to question whether some of the interventions should be more nuanced in both areas. So how could people who have got severe depression be kind of reduced to attend A&E, and are there other things that could be placed within primary care to help support that? Another thing to be really mindful of, I'm currently leading a study in A&Es, and one thing we're finding when we're visiting individual A&Es is the fact that suicidal crisis in some areas is actually coded as depression. So some of these numbers as well for attendances for depression, I think need to be unpicked more, and hopefully we'll be doing that with some of our future research to see actually if we're getting an overrepresentation of depression that's including a group of people who are also attending for self-harm and suicide as well. So just for the final slide on future implications, we're looking at future interventions, as I said, to improve access to primary care, as these may be more effectively targeted towards younger adults, given the increase in those groups. Again, I'm leading on some work where we are implementing self-harm interventions, and we are finding in the initial phases that there are more young people who are taking that up, and a lot of students as well. So I don't know if that kind of corresponds with some of this work, but we'll see in the future. The findings also suggest that we may need more expertise in A&E and GP practices to be able to deal with severe mental health issues, in particular depression. Our findings validate the 2018 NICE guidance about the focus for comorbidity, and that we need to have services that address people's wider health and social care needs, such as poor housing, that has come up in each stage of our analysis as being significant. and for future research into the social attributes that contribute to reduce A&E and GP attendance rates is needed to look at that in more detail. So that is everything from me. I'm not sure if I've gone too fast, but if I have, we'll have more time for questions. So yeah, thank you very much.
Great, thank you very much, Pooja. That was pretty much bang on time, so well done. So does anyone have any questions about Pooja's talk and Pooja's analysis of the HHS? No questions yet. Well, if you think of any others, you will have time to talk to Pooja about them in her breakout room as well. So thank you, Pooja. I don't think there's any questions at this point, but there may be some more coming in. So, okay. Oh, there's a question from Lisa. Okay, there you go, Pooja. How do you plan to target A&E staff development? Can you answer that?
Yes, I can actually. So thanks for the question, Lisa. Well, part of the study that I was saying we're conducting at the moment, looking at people who are attending A&E for suicidal crisis, self-harm, and suicide attempts, we're actually doing some work with the staff, because what's come out of our preliminary conversations is the staff telling us themselves about some of the attitudes that staff have within meeting the constraints of the service and what they can provide as care for people coming through to A&E. So we're doing some work on looking at staff attitudes for people attending with some of these issues, which will include severe depression as well, and to see whether we can work with the A&E services on improving, I suppose, the environment for staff and the people attending, that then may in turn hopefully improve the conditions and outcomes for both staff and patients.
Yeah, okay, thank you, Pooja. So unless there are any other questions, just a bit of a side note, because our agenda got a little bit updated yesterday. So unfortunately, Dr. Jenny Downing can't join us today. That's why we're short of one presentation. But so that means we're now going to start moving into our breakout rooms. So we will have 30 minutes of breakout room discussions. And if you have a look at the chat box, we will have 3 different topics. So the first topic is looking at implications for mental health policies, led by Professor Rhiannon Corcoran. If you're interested in joining that breakout room, just don't do anything, stay in this room. If you want to have a chat with Dr. Pooja Saini about service usage and barriers for mental health, there's a link for her breakout room, mental and physical health, I think. And breakout room 3 will be led by Professor Mark Gabby on health and service usage in coastal areas. So again, there's a Zoom link in the chat box for this. So if you all want to decide now, either click on those different Zoom links or just stay here, and then we'll have a chat. And then we'll have afterwards at 1:30, we'll all come back to this bigger chat room and we'll have a little wrap up, and then we'll finish at 1:45. Just checking, Rhiannon, are you there? Yes, you are. So people are just joining other rooms now. But Rhiannon, if you want to take over your group discussion.
Yeah, sure, will do.
Sorry, I'm really sorry. I couldn't join group 2, Pooja's. Could you help me? When I join the link, Clarissa, it won't let me join the, do I need to come out of this meeting and join it?
No, you should just be able to click the link. Sorry, I haven't set it up.
Sorry. Okay, I'll give a go again. Thanks. Sorry about that.
I'll start then. I'm assuming Sika will be able to join Pooja's when she can. If not, you're very welcome to stay here. So welcome everybody to this breakout session, where I think the purpose really is to think about the findings across the mental health papers that you've heard about today, to think about how they might lead to certain recommendations about how we perhaps treat or consider mental health into a broader framework beyond sort of, if you like, clinical treatment. So you will have received yesterday via Debbie, I think, or possibly Clarissa, the abstracts of the papers that have been presented today, and I think maybe some others as well that weren't presented. And I'm just going to share my screen now so that I can highlight the particular things that are mentioned in the conclusions of those abstracts that we might want to focus on. Just to note as well that Anne Lear is very kindly running a Jamboard behind this session, so she can be taking notes using Jamboard, which she can share with us 5 minutes before the end, Anne, so that we can have a look at how things are gathering pace and what people's thoughts are. So when you speak or when you have anything to say, just be aware that Anne will be typing furiously in the background on post-it notes to try and record your main messages. So I'll just share this screen now then. So I'm hoping you can all see that. As I said before, you will have received these yesterday. I think you may not have picked them up, but they were sent out yesterday. So I'll scroll up to the top. So this is the paper that Jason talked about, or at least one of the papers that Jason talked about today. And in this, I've highlighted in yellow the things that I think are potentially important in relation to thinking about where does this research lead us in terms of thinking about mental health policy, mental health care and treatment, and the approaches that we take to understanding mental health generally as a society. So the first thing I've highlighted here is that there was a demonstration that stronger identification with one's local neighbourhood attenuated the adverse effects of financial stress on self-esteem and subsequent mental health. So you remember that from Jason's presentation. So this was the really important finding, that identifying with your neighbourhood could reduce the effects that you feel because of financial stress. And then the other thing I've highlighted here, the findings suggest that one way financial stress impacts mental health is by eroding self-esteem. Identifying with one's current place of residence appears to disrupt this pathway. So that's more or less saying the same thing. So while we know, in other words, that things like financial stress can affect our mental health, there are ways of mitigating that effect. I mean, obviously, what we'd really like to do is to make sure that people aren't under financial stress. But given that it's unlikely that we're going to be able to do that successfully, one way of doing it would be to consider increasing the sense of identification with neighbourhood, because that will buffer, that will protect you against, if you are financially stressed, mental health difficulties. So the second paper was Helen's, which you heard about. So this is around suicidal ideation, suicidal thoughts. So I'm just going to scroll down to the conclusions of Helen's abstract. The study suggests that it could be useful to increase community support and sense of belonging using a public health approach for vulnerable groups, e.g. those with cancer, and peer support for people who are identified as LGBTQ and or BME. Also, interventions aimed at increasing empathic functioning may prove effective for reducing suicidal ideation. So again, you'll remember Helen's presentation on this. The idea around increasing community support in potentially different kinds of ways, including sense of belonging, but also peer support and potentially ways of increasing empathic functioning may be important. So that last one feels a little bit more like, if you like, a psychological intervention than the others, I think, which feel more societal. So on to one of the papers that Clarissa has led, the longitudinal Northwest Coast Survey exploring health inequalities in disadvantaged communities. So Clarissa et al. Conclude mental health, physical health, employment and housing quality were poorer in disadvantaged neighbourhoods than in relatively advantaged areas. And this is a sort of overarching paper around the HHS. So this survey provides important insights into socioeconomic variations in physical and mental health, with findings having implications for improved care provision to enable residents from any geographical or socioeconomic background to access suitable care. So it's really highlighting the disadvantages in terms of care and the use of care. And then this is another of Clarissa's papers. So do people living in disadvantaged circumstances receive different mental health treatments than those from less disadvantaged backgrounds? So really looking at the role that where you come from, what role that has in terms of what treatment you take or are offered. And I think that's an important distinction. And again, this was a first. This appears to be the first study showing high levels of treatment with medication and psychological therapy in people from disadvantaged backgrounds. Future research needs to address the underlying factors associated with increased mental health treatment uptake in people from lower socioeconomic backgrounds. And so I think that we had expected to find higher prescription of drugs, in particular medication, in those from disadvantaged areas, but we actually found higher levels of psychological therapy as well in those disadvantaged areas. And so understanding that a bit more and why that is, I think is really important. Social and mental health predictors of emergency department and general practitioner use. So this is what Pooja has literally just presented to you. And a number of different findings in that paper, as you'll recall, but here's a sort of conclusion. Having a higher number of mental health symptoms was associated with higher GP and A&E service usage. Depression was the strongest symptom predictor of A&E attendance, while anxiety was the strongest symptom predictor of GP attendance. And in conclusion, mental health comorbidities increase risk of attendance to both A&E and GPs. Further research into the social attributes that contribute to reduced A&E attendance and GP attendance rates is required. So there's a direct recommendation about research in that paper. And then this paper looking at public involvement in the dissemination of the Northwest Coast Household Health Survey, another led by Clarissa. Members of the public shaped the dissemination of evidence and provided guidance for future steps. Public advisors were mostly positive about their involvement in the dissemination of the HHS, but highlighted the need for more transparency and support from researchers. So this will be about recommendations to improve co-production in research, I think. And then this is the paper that Owen McElroy led that I spoke about not so long ago around mental health and neighbourhood social environment. These domains were linked primarily by paranoia, as you'll recall, although only in the most deprived group. Drunken rowdy behaviour was particularly influential within the neighbourhood cluster. Therefore, policies aimed at reducing such disruptive behaviour could have positive knock-on effects for social cohesion and mental health. And then finally, the paper that I presented, which is under review currently, around well-being and subjective well-being. So the findings highlight the complex relationships that exist between individual and place characteristics in the context of subjective well-being, and that both domains need to be considered when developing population strategies to improve well-being. further consideration needs to be given to how this might happen in practice, for example, through a combination of consistent use of community engagement methodologies alongside health in all policy approaches. So I think what you're seeing, I might just stop sharing that now and go back to full screen. What you're seeing is a fairly consistent picture of the findings relating to mental health and the association between where we live and the symptoms of mental distress and or low well-being that we see. So and then there are other recommendations, like involving PPI in co-production of research, etc. So I'm gonna sort of open it up for your ideas around if we were to write a paper on the basis of our mental health findings using HHS data that was focused on evidence-informed policy recommendations, what should it emphasize? So if you just want to have a think about that for maybe for a minute, and then we'll open up the discussions. And do you want to just show the Jamboard so that everybody understands what it is that you're going to be doing in the background while people have a think about that?
Rhiannon?
Yeah.
Can I just ask you whether you want ideas around, you know, next steps in terms of new research, or this is more about what is important about what's already come before in terms of some sort of summary paper?
Yeah, no, it's a good question, Selena, and I think it's a bit of both. In my mind, I had recommendations to make in a summary paper to do with how we, as I say, how we conceptualize and therefore how we treat, for want of a better word, mental distress. So a bit of both. So Anne, do you want to quickly talk us through the Jamboard?
Yes, there's a link in the chat, so if you want to add one of the post-it notes, please feel free to do so. Otherwise, if you can't do that, just put a note in the chat and I'll add a sticky note onto the Jamboard for you. So this is just a virtual post-it note board.
And what we'd hope to do, if we have time in the final 5 minutes, is maybe to thematize some thoughts around the stickies that have come up. So it's open for discussion now then. So while this is sort of focused on the things that you've heard that have come directly from the HHS, it doesn't have to be solely based on those findings. They should be, I'm assuming, consistent with your own expertise in these areas.
Can we start?
Yeah, okay.
Yeah, I was going to say, first thing comes into mind with me, Rhiannon, is my experiences in my neighbourhood of antisocial behaviour and whatever else. And there's quite a few things, so I'm not going to go into everything. But one of the biggest factors that helped in my neighbourhood was when everybody came together, the local authority, the police, everybody, and said, last, something's going to be done. And that's how it was when you're feeling desperate to get something done, because I did get to the stage that I was going to take on Lancashire Constabulary and, well, anybody that's in positions that could help me, and they were not. I was prepared to do something, even when I felt so unwell, but had to do it. You know, you just can't go on. So that's one factor. And what came into mind is, are all GPs on board with mental health? That's still a factor, okay? Because when I removed my GP, best thing I ever did. But I have a relative who's a GP, and when I ask him things, and he hasn't a clue about certain things in mental health. So GPs, that's another issue. Can you trust your GP?
Those are really good points. Thank you. And just to summarise then, you're suggesting that different sectors within the governance of places need to join up to combat what's sometimes called these complex or wicked issues to do with places.
Yes.
So that's the sort of idea around breaking down the silos of governance, I suppose, isn't it?
Mhm.
And then something to do also with the training of GPs around mental health.
Yes.
Yeah, okay, that's lovely. Thanks. Pamela, I see you've got your hand up.
Yeah, so I would I would totally agree with both of those comments. I don't think people listen enough to the people who live in these areas, and it's not just GPs. I teach nursing, and I'm very concerned about the attitudes that people have about behaviour, and that person needs to do something about this because this health behaviour is a risk. Well, telling somebody that they need to stop smoking who's living in an area where you've got these sorts of problems, we can't do, because we're just setting them up to failure. And it's joining those dots, and most health professionals do not get that.
Yeah, I think that's a really important point, Pamela. Thanks for making it. This rather fake distinction, although I did it in the network analysis myself, between the individual and the place just kind of doesn't work, you know, because our behaviours come from the context in which they happen. And so that disconnection needs to be, it's a myth, and it needs to be tackled, I think, in policies. Thanks for that, Pamela.
What's interesting, if I could just add, in France, because I was in France for 25 years, they no longer have mental health and physical health nurses. It is one training, and that made everybody more aware of both issues, whether they were working in mental health about the physical health of that person or physical health about the mental health. And I was quite shocked, but in actual fact, when you see the problems that we have, that was quite a good idea.
Yeah, thanks, Pamela. That's good. So about the again, the sort of myth around the difference between physical and mental health needs to be tackled. I'm going to take Lisa now because she's had her hand up, and then I'll come to you, Selena.
Hi, thanks for that. Yeah, just to say, brilliant talks this morning. The research is really fascinating. I'll try and be clear. I've got a fuzzy head. I had my COVID vaccine and I've had an allergic reaction to it. So I have got a bit of a funny head going on. But forget that. Don't let that put anybody off. Sorry. God. So in terms of, one of the things that I picked up on was the concept of people from lower socioeconomic areas more likely to get prescribed antidepressants, and also more likely to be engaged in psychological intervention. And so initially you kind of go, oh, well, what is it about people from higher area, you know, more affluent areas? Is that because they're not accessing service, or they're paying for service, or is there something else going on there? But actually, for me, there was a few more questions about the people from lower socioeconomic areas. Is it that people are just being passed through the service quite quickly, as opposed to actually looking at the complexity of problems for people? So is it, I'm not trying to criticize primary care, but is it that we're passing people along to say, just go and deal with it, it's in your head? And as a health psychologist, this is where I'm coming from. As a health psychologist, actually mental health isn't an isolated position, which I think is where Pamela has just made the point. So is it actually, again, there's a point here for future research to really go into that in a lot more detail about people from both lower, higher deprived areas and more affluent areas. So that was that point. And then I really loved the network analysis work that you presented. And we are moving. We've got KTP funding, and we're working with Cobalt Housing in North Liverpool. So Cobalt have 6,000 homes, which they rent to their tenants, and we're going to be targeting all 6,000 homes. But within a sample, we're working with Built Environment to look internally at people's behaviour in the house, but also how they're building, how their home operates. In relation to sensors and temperature and all of those sorts of factors. And so with COVID, as an example, we've all been embedded in our homes much more. So looking at that internal environment is something we're going to start looking at, and I'm very keen to sort of understand this concept of network analysis. So that's an area of maybe of development that could link in to this work. I'm sorry, I'm aware I've mumbled a little bit there.
Not at all, you haven't. Thanks, Elisa, for making those points. I mean, I think that the finding around higher medication and higher psychological therapy in the more disadvantaged areas is a really critical one. We've seen it before all over the news. For example, the Valleys of Wales has the highest level of Prozac prescription because it's incredibly disadvantaged. And so we're potentially now seeing this also coming out because of the NICE guidelines and translating into psychological therapy. But for me, there seems to be something to do with, if you come from a deprived background, you go off to your GP or your specialist and you say, I'm feeling really terrible, instead of saying, and this relates to the sort of cartoon I put on my final slide, instead of saying, well, no wonder, you're living in a place that is disadvantageous to you and it's unfair, they're saying, okay, well, off you go and get some treatment for it. And it just seems completely the wrong approach to me. And I don't think it well, it probably does matter, but I don't think it necessarily matters that whether or not it's drugs or psychological therapy, because the psychological therapy that's offered is often pretty useless anyway, to be frank. And it's not addressing the key concerns of people, which are, as we've seen through all the presentations, something to do with how we're living. Ian. Oh, hi, yeah. Sorry, Ian. May I just go back to Selena, because she had her hand up before you.
Okay, that's no problem at all.
Selena.
Sorry, Ian. Yeah. So just my thoughts on it were that the medication and the psychological therapies is increased levels. It is theoretically an example of good care, in that we're expecting levels of depression and anxiety to be higher in these areas of high deprivation. So we would hope that they would have access to more medication and more psychological therapy. Whether or not those are good ways to deal with that, yes, I think we should have GPs recognising that there may be reasons. I'm sure they are in their own minds recognising that the reasons that those people might be having high levels of anxiety and depression and probably linked to their living environment, and we should be expressing that to people. But it doesn't solve that individual's problem, does it? So I suppose the thing for me is looking at this wider public health in all policies type approach. The things that came to mind for me about all these different research was, what do we know about what affects neighbourhood identity, if that's one of these mitigating factors, and how is that affected by different things like background, length of time in a place, different geographies, ethnicities, all those different things? How does that affect how someone's sense of neighbourhood identity is formed? And then obviously that then links to how can we increase somebody's sense of identity within a place. And then the other thing was things like increasing empathy. There's programs like Roots of Empathy with children in schools that are also linked to reduced sexual and physical violence. So that could be it. So it's going back to that, parenting, first 1,000 days, increasing breastfeeding, looking at education, and obviously from a public advisor point of view, just thinking about, yes, obviously we want co-production and we want people to be, but knowing that people might have current mental health problems that are, they're struggling with, and making sure that we recognise that it's difficult for people to be given their lived experience in these settings, and making sure that we protect people as much as we can and support them as part of the research if we're including them within that research.
Yeah, those are lots of really good points there, Selena. Thanks. Just picking up on
5 minutes. Sorry, 5 minutes.
We 5 minutes already. So just picking up on the one about neighbourhood belonging and identification, and finding out what supports that, I think is critical, isn't it? So Ian and then Pamela, and then we probably ought to wind up so we can have a proper look at the Jamboard.
Yeah, hi everyone. I'm kind of coming this from a different perspective. I'm a data scientist, and I'm thinking about Lisa hinted at it actually, is about supplementary information. Is there any idea about mapping information into these household surveys to try and address some of these wider questions you're asking and may not be able to be tackled by the survey, but supplementary information? Interestingly, someone mentioned Stockbridge Village. I was brought up in Stockbridge Village and still have all my relatives over there. And you concentrate on the people who live poorly. What about the people who live well in these areas, and trying to profile the people who live well within areas? Especially I've come up, people say I escaped, but I had a great upbringing, but I realised there was families close by who didn't have that kind of upbringing. So I think emphasis is always on, in the poor areas, people live badly. Well, that's not necessarily the case. You need to compare both and learn lessons from the people who are living well within those areas. But my main question is about mapping information into this household survey and adding supplementary information from police, from GPs into the survey, and then try and add extra flavour into it.
Yeah, I mean, as a data scientist, you'll know that connecting up different sources of data can be tricky, but Ben mentioned the place-based longitudinal database that he's developed, and so that links up into the HHS. But you're right, it needs to be potentially broadened out to involve all sorts of different kinds of statistics, including crime and policing statistics as well. Your point about poor places can be perfectly good places to live. I completely agree. Wealthy gated communities are a really good example of how not to live, because you're disconnected from other people and you tend to keep yourself to yourself within them. So those are not examples of really pro-social places. And highly bonded communities like Stockbridge Village absolutely are for some people, but not for everybody. So I completely take your point about the overgeneralization using something like IMD in this kind of analysis. Thank you, Ian. So Pamela, and then, well, Abby, Pamela, do you mind if I go to Abby first, because you've spoken and she hasn't? Is that all right?
Cool. Hi, thanks. I just had a couple of points to make. I used to work in multi-agency safeguarding hubs, and the comments around lack of training and lack of presence, I think, of mental health care professionals in the multi-agency safeguarding hubs. They've done a great job in connecting up police, social care, adult and children, and then have A&E representatives, but I think there does tend to be an absence of mental health professionals, and in specific as well, mental health advocates. And I think advocates are really important in addition to the healthcare professionals because of the lack of training around some mental health support issues. So I think these findings really back up the need for kind of that coordinated approach. And so I think that multi-agency safeguarding hubs are a really good place to start. I think that additionally, obviously a lot of these issues were related also to socioeconomic disadvantage in conjunction with mental health. And in my experience in working in community groups, the accessibility issue of accessing mental health support, people tend to not access centres of mental health support because of stigma and all the issues that we've discussed today. But people do want to access employment opportunities a lot. So I think that in light of all the issues that we've discussed today, bringing social enterprise with supported employment into kind of the approach of addressing some of these issues is really important, because supported employment and social enterprise can serve a massive role as providing employment which attracts people, but then providing a space to provide holistic support. So I think any part of the dialogue really needs to be in conjunction with local social enterprise.
Yeah, that's a really good point. Thank you, Abby. A number of good points, actually. Thanks for making them. And just to point out that, a more connected up approach is going on in initiatives like the life rooms in care, where you get citizens advice coming in, where you get employers coming in, where you get access to different voluntary activities, those kinds of things to support mental health. But the points you make are well taken. Thank you very much for them. And finally, I think, Pamela, because we need to have a look at our Jamboard. We haven't got enough time for these things, have we?
So I would wholeheartedly support what Ian said. I come from Speke in Liverpool, which is a very, very deprived area, and there are positive aspects of those communities that we need to build on. And I think we could use the resources that we have by using undergraduates who would go into those communities and learn from those communities and give back as well. So we're actually creating a dynamic for advocacy in those communities by using healthcare students who then will learn about social determinants of health.
Great, thanks.
I'm mindful of time and really interesting discussion, Rhiannon, but all the other people are joining us now. So
we won't have time to look at our jam builder, but I'm hoping Anne might be able to send it around. So after we've had a look and tried to pull things into themes, perhaps it can be sent around.
Yeah, and sorry, let's just wait a few seconds for everyone to join us again. Okay. Well, Rhiannon, yours was breakout room 1, so I hope everyone's had good chats and discussion in their individual breakout rooms. But Rhiannon, do you want to give a brief overview of the discussion points? We've got a couple of minutes for each room.
Yeah, so I suppose it's quite difficult to pull it all together without having had more time to think about the synthesis. But so there was discussions around, quite a lot of discussion around increased use of medication and psychotherapy, looking like the inverse of the inverse care law, which is interesting, but also trying to understand why and how that might happen. People talked about multi-agency working and about bringing agencies together to tackle the kind of issues that we have in our communities and societies that impact on mental health. People talked about the way that some of our analysis, which was focused on IMD, sort of led to the erroneous idea that all places which are disadvantaged are bad to be in, and that clearly is not the case. And I think that's a really important point to bring out. And so there was some suggestion that we look at people who do well in disadvantaged places, so that we can learn about how how they manage. I think we've got some ideas about the answers to that potentially already. People like Steph's work in Stockbridge Village, for example, is really useful in relation to that. But incredibly in-depth and rich discussions. So thanks everybody in the breakout room that I led.
Yeah, thank you. Pooja, do you want to give an overview of your discussions?
Yeah, sure. So we were looking at service usage in more detail, and on the barriers for mental health and service usage, basically, either A&E and GP. So we had some really interesting discussions. The first thing was about people who maybe are actually avoiding those two areas and going directly to seek help for mental health from third sector organisations or privately, and looking at the rates of that and whether that has differed as well. Looking at stigma and people feeling judged, also people accepting themselves initially, whether they feel that what they want to discuss is the fact that they've got mental health issues, discussing that with the people around them initially, and then also the barriers of them maybe seeking help, maybe needing that social support or family support to seek help. Then we also talked about the barriers when people may seek help, and that might reduce them seeking it again, is if they get quite judgmental or negative attitudes from people because they're seeking help for their mental health. And also how hard it can be to talk about these issues in a 10-minute consultation or other short consultations, and that people may not know how to actually succinctly talk about what their mental health issues are in a very short space of time, or know themselves what they need. And And then another interesting point was the fact that people still having that attitude, you know, generationally about getting on with it and, you know, pick yourself up and you'll feel better, or go and do this and you'll feel better, and still that kind of lack of acceptance that may create barriers as well. So I'm sure I've missed stuff off there, so apologies if I have, but really interesting discussions.
Great, thank you, Pooja, for summing up. Sounds really interesting. Mark, do you want to share about your discussions?
Can you share the Jamboard, or can't you do that?
I can, 1 second.
Just so that we do something different to keep people awake.
I can't share, sorry, Clarissa.
Unless Clarissa gives
you can
like...
do now, Pallavi.
Thank you.
So we were looking at coastal. So we have something now in the ARC called the Northwest Coast Seaside Towns and Communities Research Development Network. So I was sort of talking about that. And we had quite a small but beautiful group of 8 of us in ours. Only I think one lived on the coast, and I see Keith is here, who's actually part of that group anyway, so he went off to do something different, quite rightly. So we were looking at what we're trying to do in our coastal seaside communities, and some of the developments that were happening, and introduced the topic. And these are the things that came out of the discussions, looking at some of the challenges and maybe some of the solutions. And then towards the end, we talked about how one might collect data and the strengths and limitations of current data sets and how they might be improved. And there was a discussion around how data is one thing, but actually engaging with people and understanding what motivates them, and sort of qualitative data and mixed method is also very important. But the word holistic came up quite a lot, and thinking about engaging with communities for them to be empowered to make changes, and for those changes to be sustainable is the key. And to look at what you can do, not what you can't do. There's lots of things that one can't do or won't do, but it's important to try and share what bits we can do. And that also sometimes encourages local authorities, when they start thinking about the next election, to maybe do things that they've avoided doing because there's a groundswell of opinion that says we now expect you to do this. And remember, there's an election in May. I always think that's a useful thing to do with local politicians, because there doesn't take many people to vote to unseat a local councillor, because the turnouts are so small. So if you get a groundswell behind a particular action, you can make quite a big change. So that's really that's the bit I've added at the end about the politics of doing it, by the way. But I hope that's of interest. And if anyone is coastal, seasidey, please do come along to our meetings. There'll be the timings of them are put up on our life course theme, because we host that network research development.
Great, thank you, Mark, for summing that up. So it seems like 3 separate interesting discussions have been going on, and we will produce some quick overviews of that as well. But yeah, that's really it. That's been the conference.
Okay, well,
so I hope, sorry, Mark.
Well, I would just like to thank yourself and Anne and Pallavi for the incredibly hard work you've done to pull this together and to make it happen behind the scenes.
And Debbie.
And Debbie, sorry, Debbie as well, because sorry. Because I think it's gone really well, and I'm incredibly impressed how well to time it's gone, even though they weren't pre-recorded, even though you weren't shouting at people. I think people have been really disciplined about keeping to time, and it's been a fascinating conference. I hope everybody else agrees. I don't think there's a clap function. Oh yes, there is reaction, so I'll start that off.
Great. Thank you, Mark. No, it's certainly been interesting to dive back into the HHS findings after we've finished data collection. So great, a frame full of clapping hands. This is exciting. So thank you everyone for joining us. I hope it's been interesting to you as well. And we will upload the recording of this conference to our ARC Northwest Coast YouTube channel and then I'll send you this via email. But yeah, have a good weekend, everyone.
So,
thanks for joining.
Spoken like a true ARC director, can I remind colleagues who are actually at this meeting who are still doing HHS papers that there's no time like the present. So let's try and get them finished, and then we can potentially produce a package of papers together on the website where we can put them all into one place. Okay.